Good afternoon, sir.
Yeah, hi Atna, how are you? Good
Fine,
afternoon.
thank you, sir. Long time, sir, since I've seen you.
Yeah, yeah. How are things?
Okay, sir, going on. All fine, sir. Thank you.
You're at St. John only, na?
Yes, sir, very much.
Rishit, are you there?
Yes.
Rishit, please start the session.
Yes. A very good afternoon to all of you. And after the inaugural session, now we are moving to our first scientific session of Hall B. And here the focus is going to be on nutrition in special populations. And for this, we are going to have a variety of talks, which will be focusing mainly on nutrition in pediatrics, nutrition in elderly, palliative care, pregnant female, etc. So the first session is nutrition, for which we are going to have two panelists, the two chairpersons. So I would like to introduce Dr. Sanjeev Gulati, who is the chairperson of nephrology and kidney transplant at Fortis Group of Hospitals. And I would also like to call upon Anuja Agrawal, madam. She is a senior dietitian at the Department of Pediatrics at AIMS, New Delhi.
Thank you so much.
Thank you.
Thank you. So, so who would like to, introduce the speaker?
Yeah, you can go ahead, Anuja. Yeah.
Okay.
Ladies first.
Okay. Thank you so much. So, good morning, everybody. And at the outset, I would like to thank the organizers to give me an opportunity to chair this session. And our first speaker who is going to speak on pediatric patients with kidney disease is Arpana Iyengar. She is a professor of pediatric nephrology at St. John's Medical College Hospital at Bangalore. And her achievements are she's chaired the International Society of she's a chair of the International Society of Nephrology Clinical Research Program from 2001 to 2023. She is also an editor of ISN Academy 2021. She's also on an executive committee member of ISN South Asia 2019 to 2023. Also a core committee member of ISN WHO Initiative for End-Stage Kidney Disease 2020. So over to Arpana Iyengar for your talk. Thank you so much.
Thank you so much, madam. I'll share my slides. Good afternoon, and thank you very much to the organizing committee of the SRNM for giving pediatric renal nutrition this special space in this conference. And I'm sure all of us are very aware that when it comes to nutrition and children, it is definitely different. Children are quite resilient and they adapt to whatever they are told to. And that applies even to nutrition or diet restrictions or supplementation. So today what I'm going to discuss is based on three important aspects of concepts in renal nutrition with respect to CKD, assessment tools, and management principles. Coming to concepts first, I would like to show a few pictures of children so that one gets an idea how this entity manifests in children, that is malnutrition, which consists of both undernutrition and overnutrition. So you have these kids who are on peritoneal dialysis. The second boy who's 14 years old, can't believe it, isn't it? Only 15 kgs body weight, is so emaciated. And that is the child who succumbed because of undernutrition also playing a very important role apart from his other comorbidities. And you see a 4-year-old who is weighing 30 kgs, and that's the other extreme of malnutrition. So based on the WHO guidelines or definitions, we have undernutrition and overweight as the two ends of the spectrum of malnutrition. Does nutritional status of a child matter in CKD? it's been seen that short stature and poor appetite are associated with low health-related quality of life scores. And this is not only true for the Western cohort of kids, but we have ourselves in our center studied this association of short stature, poor appetite with low health-related quality of life. We all know it is also very as well established in adults that malnutrition is an independent predictor of mortality in CKD. In children, the height is a very important parameter. 14% risk with a decrease in 1 SDS of height is associated with mortality, and the higher risk with height, which is less than -3 standard deviation score. Weight also has a bearing on mortality. The higher mortality is seen with 5% reduction in weight in 3 months. And when it comes to BMI, 6% risk in the death with a decrease in 1 SDS of BMI. Serum albumin has been noted to be associated with increased hospital admissions. So yes, it really matters. So how common is undernutrition in CKD? Now, undernutrition has been defined by various studies in different ways. If you look at only growth failure, which is a very unique parameter to children compared to adults, the proportion or the burden is in the range of 37 to 55%, undernutrition 20 to 60%. And then the third aspect is something that is again very well established in adults, that is protein energy wasting. And very few studies have actually dealt with this entity in children. The CKID study has dealt with this, and the proportion of mild PEW, protein energy wasting, to severe forms would be somewhere between 7 to 20%. And a study from, again, our center has shown that the burden is much higher. I'll come to the details in a bit. We undertook an observational study a few years back looking at the various comorbidities in CKD stage 2 to 4. And you see the cohort that we looked at. Of course, the numbers were 78 versus, if one compares with the CKID study, which is the largest pediatric chronic kidney disease cohort from the West, you see all the comorbidities except obesity. You have higher proportions of vitamin D deficiency, left ventricular hypertrophy, short stature, dyslipidemia in our kids. So definitely we have growth failure, but obesity is very, very less compared to the Western cohorts. As pediatricians, we are very familiar with this term protein energy malnutrition, PEM. And now we are getting more familiar with this entity protein energy wasting. We are still exploring the best definitions that could be used to approach the diagnosis of PEW in children. So the basic difference between PEM and PEW is as follows. In PEM, there is reduced fat. In PEW, usually fat is preserved. PEW is seen classically in chronic diseases, and chronic kidney disease is no exception. But PEM is classically used in situations where there is a nutritional intake deficiency. Muscle is usually preserved in PEM. Muscle is lost in PEW. There is decreased metabolic rate in PEM and increased metabolic rate in PEW. There is usually increased appetite, and therefore we have a good rehabilitation and reversal of the malnutrition in children. But in PEW, there could be decreased appetite, which again precipitates or challenges the recovery from the protein energy wasting state. And there's a good response to supplementation in PEM versus the response to supplementation or intake is not, it could be variable, and that alone would not suffice to manage a child with PEW. This is the proposed criteria for PEW, which was came out in this paper in 2014, wherein you have 5 criteria: the serum chemistry, the anthropometry for body mass, anthropometry for muscle mass, and dietary intake, and finally the poor growth category, which is again unique to children. So 2 categories are unique here to children or different from adult PEW criteria, that is short stature and dietary intake, wherein we are not actually calculating the calories and proteins in this criteria. We are just focusing on appetite. And they have various scores to define whether you are in the mild PW category or the more severe category. So we undertook a study on protein energy wasting, and in CKD stages 2 to 4, you can see with the number of children of 123, again comparing this with the Western data, the burden is much higher. The severe PW 64% versus 20% in the Western cohort. Coming to the second part of my talk is assessment tools. We have had a long gap between the previous guidelines and the recent guidelines. The KDOKI 2009 has a dedicated recommendation issue for children with CKD in terms of nutrition. And the Pediatric Renal Nutrition Task Force has proposed the clinical practical guidelines in 2021. So these are the various parameters that as a pediatric nephrologist, one would evaluate a child with CKD for nutritional status. However, we all know that there are various challenges in the assessment itself. Now, a child is in the growing dynamic phase of growth in childhood, and there could be changes in body composition. Edema is a very important confounding factor. Etiology of CKD also matters, because if you have a child who's got an underlying tubular disorder, then they progress slowly and probably the growth gets affected more compared to a child who's got a rapidly progressive GN who gets into ASKD within a few months. There the growth may not be that very affected compared to a chronic tubular disorder. Other medications affecting growth, we use a lot of steroids in both nephrotic syndrome and other glomerular diseases, so that could affect growth. Comorbidities like the bone health and bone mineral balance also matters. And the unfortunate part is that be it adults or children, there is no single tool that is ideal to define or characterize this challenging status of nutrition. So here I'm going to just illustrate that body weight is composed of various compartments. That is fat-free mass, the fat mass. You have the cellular tissue mass, then you have the bone and the other non-active components, and then you have the total body water, which is again divided into intracellular and extracellular water. Then you have the extracellular mass, and then you have something called the body cell mass. So when we are looking at anthropometry measures to define or to characterize nutrition status, we use the mid-arm circumference that is a surrogate of both FFM and FM, and the body mass index is also a surrogate of these compartments, the fat-free mass. Skin fold thickness reflects the fat mass. But we don't have anything else that directly reflects the other compartments you see, which comprises of our complete body weight. So there are limitations in the anthropometry, in the biochemical parameters when it comes to assessment in children with CKD. Many of these parameters are underestimated. Some of them are overestimated due to various factors, maybe fluid overload, maybe edema, maybe other causes of short stature and growth failure. So we set out to look at some of these entities in detail in our kids from resource limited region, or you could say developing nation. Is body fat deficient in our kids with CKD? And this was published in the Indian Journal of Nephrology. We had 33 children from stage 2 to 5D. And we saw that the mid-arm circumference was low in 60%. That was a big number. But if you see the low body fat, that is body fat mass index, was low only in 18% by a DEXA scan and 12% by impedance. So there was no difference in the proportion of low body fat between CKD 2 to 5 and the children on dialysis. So though the mid-arm circumference was low, we get to know here that probably our children are preserving their fat mass, or the fat compartment is well preserved compared to the other compartment which makes up for the mid-arm circumference, that is the muscle mass. The next study we undertook, and this is published in the Journal of Renal Nutrition last year, is protein energy wasting common in our kids with CKD? So we had 123 children, CKD 2 to 4, including those on dialysis. and the proportion of them with PEW was 58%. Appetite and anthropometry measures were more useful than the biochemical criteria for diagnosis of PEW. So we came out.
I hope you can.
So we came out trying to explore this definition that I had just put up a little earlier. And inflammation, though common, was associated with PW only in CKD 2 to 4. So in children with dialysis, though inflammation was very common, it was not associated with malnutrition or undernutrition or wasting. The slides are not moving well. Excuse me for this. Yeah. And the next study we looked at is the Subjective Global Nutrition Assessment, the SGNA, what is usually termed as SGA in adults. So though we know it's a non-specific and semi-quantifiable tool, SGA occupies a very niche segment in the adult dialysis patients. And we wanted to know how it fares in children on dialysis. So we had 40 children on dialysis. We followed them up over a median period of 1 year. And we looked at the profile of malnutrition defined by the SGNA in these children. And this is what we came as to conclusions. 2/3 of children on chronic dialysis were diagnosed malnutrition by SGNA. Majority remained in the same category of nutrient status on follow-up. That's important. Only half of the SGNA parameters were strongly associated with the presence or severity of malnutrition. So again, just like PW, we were able to pick out the most important and relevant parameters that were associated or that would help us make a diagnosis of malnutrition in children. So it's not enough just to extrapolate the definitions and criteria that are already laid out for adults and extrapolate them and then apply them in children. We got to study these same criteria in our group of children and see what role these tools play. There are very many studies on CKID, pediatric nutrition in CKD. Many of them trying to highlight that the high intake of calories, proteins are present when they are evaluated. Despite that, they have malnutrition. The GFR less than 30 is associated with greater risk of poor appetite. In adolescents, lower GFR and obesity is associated with greater screen time, and lower hand grip and strength and frailty are concepts that are coming up even in children. So having said that, the anthropometric measures are just surrogate markers of the fat-free mass compartment. We know that the bioimpedance is a tool that helps us assess the total body water and gives us an estimate of the intracellular and extracellular water. Of course, the DEXA scan is a much more valid tool for fat-free mass. And I would like to highlight the compartment which you see on the left-hand corner, body cell mass, because that is the metabolically active tissue, and I'll come to that in a bit. So what about body impedance, bioimpedance? Bioimpedance has been used in our center to target the dry weight. And you can see here that we are trying to target the dry weight by having a reference ellipse of the biovector analysis in controls, and then plotting the resistant versus reactants on this graph to see that children achieve their dry weight post-dialysis. And we also have studied this on a longitudinal cohort, wherein we are able to characterize whether these children are in an overhydrated state, dehydrated, low body cell mass, or an increased body cell mass quadrant. So did you know that we all emit gamma rays? This is very interesting. Yes, we all emit gamma rays. And where are these gamma rays coming from? They're coming from the naturally radioactive potassium-40, which is intracellular. And we know that 98% of our potassium is within the cells. And therefore, if we can if we can capture the gamma rays that are emitted by this intracellular potassium, we probably would be able to interpret what our body cell mass is, because this is a metabolically active tissue. And that is the research that I am presently undertaking. And this is the whole body potassium counter. The child sits in this for about 30 minutes, lies on this for 30 minutes, and there are sodium iodide detectors that detect the gamma rays. There is no radiation side effects here. And then we will be able to capture the potassium content and the body cell mass in kgs. Coming to the last part is management principles. We have clinical practice guidelines for energy, protein, calcium, phosphate in children, and nutritional therapy is now guided by the suggested dietary intake, which is a little different from the recommended daily intake. And we have tables that give us the range of values for this, and we refer to them. Infant feeding is a very important aspect when it comes to pediatric nutrition, and we have very different and specific ways to approach this problem. Gastrostomies are rarely required, but yes, when it is required, it does do a lot of good for children who need to gain weight. And this is the way a practical example of an 18-month-old girl with ESKD on chronic PD who weighed only 6 kgs. The energy required was 447, the protein was 7.8, and fluid was 600 ml. And most of our patients that we in our center cater to cannot afford expensive supplements, and therefore you see we use the F75 and the F100, which is supplied by the WHO, and we use them for diarrhea rehabilitation. We can use that in these situations. So we did that, and we quite achieved good nutrition supplementation. TPN also can be rarely used with Cabiven. And for children on dialysis, we prefer the Reno Pro because it's got no phosphorus and low potassium. And intradialytic parenteral nutrition is something that we have not really used in, we have not had good experience or in our center, but there are specific indications for intradialytic parenteral nutrition. This is a study that we undertook to look at hyperphosphatemia, and as you can all guess that children even with CKD 2 to 4 have got hyperphosphatemia. At least 40 to 50% of them had hyperphosphatemia, and we actually derived this pyramid. Most of the phosphate pyramids are based on continental diet, and this is based on Indian diet, and this was formatted and designed and synthesized by us. And the last part in the nutritional supplementation would be to look at the vitamin D deficiency, and this was a multi-center randomized controlled trial that we undertook between 4 centers in India. And we looked at the vitamin D dose, whether it's given as 3,000 international units daily, or 25,000 international units weekly, or 1 lakh monthly for 3 months, to see how in the intensive phase, what proportion of children actually respond to vitamin supplementation. So 75% of our children in CKD 2 to 4 had deficiency, and with supplementation, about 78% responded with normal levels. So there was a 22% children who did not respond to the intensive phase. And finally, there was no difference. We followed the 25 hydroxy levels for 1 year. And finally, there was no difference whether we gave it 3 at a daily dose, weekly dose, or monthly dose. So this was the RCT that we had undertaken. And lastly, Yes. Lastly, the growth hormone, again, is very specific to pediatric renal nutrition, and there are specific indications for this hormone to be given in children with CKD. So to conclude, children need nutrition and nutritional guidance, supplementation, whatever we call it, whether it's precision nutrition. We got to have a greater focus in this path, especially in our region. And I have gone through the concepts, the assessment tools, and the management of pediatric renal nutrition relevant to CKD. And we have got the opportunity to edit this specific series on nutrition and kidney disease from the Frontiers in Pediatrics. And I'm sure this will be a good comprehensive source to highlight the importance of pediatric renal nutrition, especially in the low middle income countries. Thank you very much.
Thank you, Atna, for this excellent talk. You beautifully highlighted the importance of nutrition in children. And a child, as she's rightly showed, a child is not a young adult. And nutrition and growth are intricately linked. That's why you have to, intervene early, intervene appropriately, because the legacy of nutrition carries on even after a transplant. And several studies, including our own experience, has shown that if these children are malnourished during the CKD period, they tend to do poorly. And Atna also highlighted in her review the studies there. Now, you showed about the prevalence of malnutrition, about 63% for protein energy wasted. Now, did you, in your dialysis segment, did you look at the adequacy of dialysis in these patients? So if you are, what I'm trying to say is that if we try to promote or prescribe optimal dialysis, it's certainly a challenge in children because, children are nobody's baby. Children with CKD are nobody's baby. You don't have insurance funding for them. The families go through, a fatigue period. But what were your observations on the correlation, if at all, between the adequacy and malnutrition?
A very important point, sir, very critical point. But unfortunately, in this study, we have not looked at correlating both.
Sure.
But definitely, this needs to be looked at in the next steps.
Yeah, because, when I happen to manage a unit which has both adults and children. And when it comes to providing dialysis for children, I've seen families cut corners. They, instead of thrice a week, they'll come once a week, once in 10 days. And on top of that, there are several myths, about nutrition in children, which add to this paradigm. And I think here nutritionists have a very important role. And not all of us are lucky to have dedicated pediatric renal nutritionists, and especially in the early stages of CKD 2 to 4. And I would ask my co-chairperson Anuja to comment on that. It is surprising that a lot of these families are putting these children on a protein-restricted diet.
Yeah.
And the guidelines are very clear. The pediatric nephrologists are very clear on that. Yet when you do a diet, a survey on this, and maybe again, Apna, you can share your experience. But majority of these children are on a protein-restricted diet, which is against all guidelines. Anuja, since you are, I think, associated with a very large and active pediatric nephrology unit, what is your experience about these families? Yeah.
Yes, sir. Thank you so much. And first of all, I must congratulate you, Dr. Iyengar. This was a very insightful talk. And let me tell you, yes, nutrition definitely plays an integral role, but then it is often not done optimally because there are so many different views of people. We are probably not universal and we are probably not together in saying what we want to say. So I think dietitians, doctors need to come together, and I'm really happy there's so many nutrition-based studies which are going on. Unfortunately, in our setup in pediatrics, and rightly said by my chairperson, that there are hardly any pediatric nephrology dietitians you will get, who are just doing pediatric nephrology and focused on that. You will not get it. And that's where somewhere we lose a path of, getting them to follow an optimum nutrition advice. And also translating the new general nutrition principles into dietetics is also a very big challenge. They land up restricting rather than giving for growth and development. Is so very important not to restrict nutrition. In our setting also, for 30 years, I was the only dietitian looking after different areas of pediatrics, not only, and there are 10 different areas of pediatrics. And when I started in 88, it was general pediatrics, and then it became specialized, super specialized, and so many doctors and DMs came in, but dietitian remained only one. So this is somewhere we have to actually, if the doctors now today are more proactive in doing nutrition and involving dietitians, we should also raise our voice in our forums to have dietitians, because you want very precise nutrition advice. Now we have one dietitian who is, and Dr. Baga, who everybody knows their unit and all, a focused dietitian who look at, I'm sure she must be attending this. I told her to attend this and listen to it carefully. And going into, going forward, there are challenges. For example, you said SGNA. We also tried in our setup SGNA. We were not really successful. So I think we need to learn from you also. How did you do it? And probably I send my younger dietitians there, and lot other centers should send, because these are the people I have seen in my experience, that later on when they have their dialysis transplantation, they remain short, and their whole life, their jobs, their marriage, then they are worried about it after they have the transplant.
Sanjeev, I will request you to wind up now, because we're already
Yeah,
behind.
I think, thank you, Anuja, for your comments.
Last word with you, sir.
Yeah, so I think it's a very important, I'd like to, first of all, compliment the organizers of Society of Renal Nutrition and Metabolism for giving us this opportunity to, highlight the importance of nutrition in kidney disease, because as we said, we agreed, a child is not a young adult, and their needs are different. And this is a critical period of growth. If you have missed this, you have missed the bus, and the child is left with a lifelong legacy. And it also adds to poorer outcomes even after kidney transplant. I think, and we should remember what Hippocrates said years back: let food be thy medicine and not medicine be thy food. I think this very well holds true for children. Nutrition is the key part in managing any child with kidney disease. And Arpana beautifully showed several studies. I think I would like to compliment her on the excellent work she's done, and we look forward to her continuing work. Thank you, Anuja, for your inputs. And thank you once again, Dr. Umesh, for giving us all this opportunity.
Yeah. Can we move on to the next one, please? Yeah, thanks.
Thank you, Dr. Arpana, and thank you, chairpersons. Now we are moving to our next talk, and we all know that eating right and staying active is very important, no matter what your age is. And hence the next talk is nutrition in the elderly. And for the next talk, I would like to invite chairpersons Dr. Harish Babu, who is a nephrologist and transplant physician at Sparsh Hospital, Bangalore, and Nimali Singh. She's a professor at University of Rajasthan, and she's the convener of Indian Diabetic Association of the Rajasthan chapter.
A quick request, so we are already running 10 minutes behind. I would request both the speaker and the chairpersons to please stick to the time schedule, please.
Yeah. Harisha? The chairpersons?
Yes, sir.
Please start.
Yeah. At the outset, I would like to thank the organizers of Srnmcon 2021, Dr. Umesh Khanna, to give me this opportunity. I would like to introduce my next speaker, Dr. Mayuri. She's a well-known nephrologist in the country. She's a senior consultant and head of the department nephrology at Srnmcon Hospital. She is also heading the renal transplant unit at Hinduja Healthcare and CAR and SL Raheja Fortis Hospital. She is in the editorial board member of American Society of Nephrology, group member Indian Society of Nephrology, and there are many more accomplishments. I'd like Dr. Mayuri to take over, and the topic is nutrition in elderly. Thank you.
Thank you very much, sir, for that kind introduction. And can I please request the organizers to let me share my screen? The message that comes is that the previous speaker is still sharing the screen.
Ma'am, please try again.
Ma'am, please share now.
All right. So, yeah. Thank you very much, Dr. Khanna, for this opportunity, and respected chairpersons for this kind introduction. So today, the topic that has been allotted to me is nutrition in the elderly with renal disease. So as we realize that this is a part of the special population, because just as Dr. Iyengar before me was given the topic of nutrition in children, similarly, I have been given this topic, nutrition in the elderly, thus re-emphasizing the fact that there is something special about nutrition in the geriatric population. The first thing that we need to realize is that old age, or the geriatric population by itself, without underlying kidney disease, is prone to malnutrition. And the fact that they also have kidney disease kind of makes them more prone to malnutrition. And the major nutritional problem that is associated with them is weight loss, which is associated with the protein energy wasting that they have. Now, if we compare the elderly who have renal disease and the incidence of protein energy wasting in them, it's as high as 50 to 68% as compared to the younger population, the population who's not the geriatric age. Of course, it excludes the pediatric population, but where it is around 25 to 50%. And the bottom line is that we are so worried about this whole concept of malnutrition in patients with renal diseases, because it increases the mortality as well as the morbidity and the quality of life in these patients significantly. Before I actually speak about nutrition, we really need to understand who's the true elderly renal patient. So at the back of our mind, we need to remember that EGFR alone is not a representative of renal function impairment in the elderly, for the simple reason is that they may have renal structural changes or a subclinical vascular disease, which we may not be able to discriminate amongst the aging, so which could be a part of normal aging, as the normal GFR drops with aging, irrespective of a renal disease. So we need to really question ourselves before we label them as renal patients. And EGFR should not be taken as the only representation of an underlying renal disease before we start, flooding them with interventions to delay the progression of CKD. Because there is a very large part of sarcopenia and just underlying malnutrition in the elderly, which is present in these class of patients, and which may influence the GFR to a very large extent. So before we actually label a patient, an elderly patient, as a renal patient, we need to be very sure that he is a renal patient. Now, what are the common causes of malnutrition in the elderly? So these reasons would be common in those who have a renal disorder and those who don't. So there are medical causes like the senile atrophic gastritis. They have dentition, swallowing problems. They have an underlying cardiac insufficiency, which may give rise to early satiety and not proper nutrition. There are a lot of mental health problems associated with old age, like depression, living alone, inability to carry out their activities of daily living because of physical or mental illness, or an underlying dementia, which may be very slow growing and not picked up. Of course, with age come other maladies, and there is a very large extent polypharmacy, which also can affect the appetite and nutrition in these patients. Now, what are the causes of weight loss? So all of these risk factors essentially do cause weight loss and the protein energy malnutrition wasting in these patients. And the most common causes are cachexia, that is essentially any chronic illness can lead to wasting, to anorexia, that is they have a loss of appetite and a disinterest in food. Sarcopenia, which is the loss of lean muscle mass, and we are going to have a dedicated lecture for this, and I'm not really going to waste too much of time talking on sarcopenia. And of course, dehydration, because the elderly patient is always more prone to dehydration and water metabolism imbalance because of age and the physiology related to it. So as I said, all of these problems together, the age-related problems, the psychosocial and the medical problems, and basically the CKD-related problems like uremic toxicity, the metabolic derangements, the inflammation which is associated with CKD, leads, the consequences that come down to is a worse quality of life, increasing sarcopenia, frailty, and eventually leading to mortality. Now, when you have an elderly patient with an underlying disease, how do you assess the nutritional status of this patient apart from the normal anthropometric measures, which we have been hearing over and over again all this time, and probably a lot more detail in these conferences? We can look at the biochemical indices like serum albumin, or if you have the measure pre-albumin. So an albumin level of less than 3.8 grams per liter, or an iron binding capacity of less than 250 milligrams per deciliter, does point towards a impaired nutritional status in the elderly. If we have to look at the whole body assessment, you can look for a BMI, which is less than 22 kilograms per meter square, or the history of a significant weight loss, which is defined as a less than 5%, 5% weight loss over the last 3 months in case the patient has an acute kidney injury or an acute renal disease, or more than 10% of the baseline if we are looking at CKD. Now for CKD, it's independent of time, whereas for AKI, we do keep a 3-month time period because that's when they have been maximally sick. You can also go for body composition where if there is a decreased fat-free mass, so which is defined as less than 15 kilos per meter square for women and less than 17 kilos per meter square in men. Or look for sarcopenia, that is a skeletal muscle index of less than 6.75 kilograms per meter square in women and less than 10.75 kg per meter square in men. We can also look for the historical symptoms like persistent anorexia, nausea, vomiting, failure to thrive, and diarrhea, which last almost daily for at least a period of 3 weeks. And lastly, you can actually sit down with your dietitian and calculate the dietary intake. So we define the decreased energy intake as an unintentional low dietary energy intake, which accounts to less than 25 kilocalories per kg per day for at least 2 months. And similarly for protein, it's a low dietary protein of less than 0.8 grams per kg per day for at least 2 months for patients who are with dialysis, or those who are on non-dialysis CKDs of less than 0.6 grams per kg per day. So here is the role of the dietitian is because they are going to have a recall and a diet diary, and that's when we are going to be able to calculate their daily dietary intake. Now, the nutritional treatment in elderly non-dialysis renal patients, why is it important is that the transition of these patients towards dialysis, so patients who are CKD stage 2 to 5 non-dialysis, they are going to eventually, the transition is going to happen towards dialysis. And this becomes extremely critical in elder patients because of a few reasons which are specific for this population. The reason being, one, we have to realize that patients of CKD who are elderly have a functional capacity which is much lower as compared to the younger generation, even before the start of dialysis. And usually studies have said that there's a steep decline in the few months just before dialysis and 1 year after dialysis. So it's only 13% of patients are able to maintain their pre-dialysis functional status. So this is something that we have to aim for with the nutritional treatment, that the patient maintains his functional status even before and even after initiation of dialysis. And that is why they require the special health care, including the nutritional care, so that their frailty doesn't increase and their quality of life remains as it was before or maybe improves. And you let them have the physical as well as the emotional independence that they had before the onset of this illness. So we obviously have the most common approach that we have is the conservative approach, which is the low protein diet, that's the LPD. Now the advantages are that it definitely lowers the CKD progression. There is no two ways about it. We have enough of data which shows that. And it also improves uremic toxicity along with improving the other risk factors that usually cohabit in the patient with CKD. So, the metabolic acidosis and the hyperparathyroidism, the hypertension, the proteinuria. So all of this is better controlled. But in our patients, in the elderly, you have to also focus on the disadvantages that it is associated with a low energy intake, which is inadvertent. It results in a negative nitrogen balance with an impaired glucose homeostasis because these patients are taking a low energy intake, they're taking low carbs, and so there is an impaired gluconeogenesis, especially important in our patients who are elderly and diabetic because they get more and more prone to hypoglycemia and of course ultimately to protein energy wasting. So the recommended dietary allowance, as we all know for proteins, is, to ensure that the metabolic requirements are carried out, is 0.8 grams per kg per day. Now, irrespective of renal disease, the protein intake inadvertently with advancing age keeps falling down, but it rarely goes beneath 1 gram per kg per day if the patient is having a standard, a well-balanced meal. Now, in contrast, it's very easy for the energy intake to go down in the elderly CKD patients. So there may be a progressive reduction to around 25 kilocalories per kilo of body weight, which is not acceptable. So as I said, that with age, inadvertent decrease in proteins do take place, but it rarely goes below 1 gram per kg per day, which is very acceptable, because in kidney disease, we anyway define it as 0.8 grams per kg per day, but we have to focus on the fact that the energy requirements come down much more drastically, and they can fall to as less as 20 to 25 kilocalories per kg per day. The end result of this is that the patient goes into a negative nitrogen balance. So there is something that is called as safe nutritional intervention in elderly CKD patients, where before you actually start restricting proteins for them, you ensure that they get a high energy meal to preserve their nutritional status. And when I say high energy, I mean 30 to 35 kilocalories per kg per day is what is necessary for them to preserve their nutritional status. Once we reach that, then the low protein diet comes into play, where you can give up to 0.6 grams per kg per day with the essential amino acid supplements and the keto acids, or a 0.8 grams per kg per day. And there should obviously be no accompanying metabolic acidosis or hypercatabolism in these patients. Along with this, you ensure a poor salt diet, but not a salt-free diet, because these patients are extremely prone to hyponatremia because of age and the physiological changes, also because of the CKD, and also because of the accompanying drugs that they may be taking at this point of time. And we also need to ensure that these patients have their daily dose of minerals and vitamins, because again, there is a tendency for these deficiencies to develop with old age. So we can promote diets which are rich in fruits and vegetables, like the Mediterranean diet, which may not be actually possible in the Indian setting, but something as close to that, which is very rich in fruits and vegetables. Now, we are going to have a dedicated talk on plant and animal-based diets in this conference, so I'm not going to really elaborate on that. But the bottom line is that, yes, we need to have a diet which is rich in fruits as well as vegetables. Now, there is a unique concept called the combination strategy or the combination intervention, where we combine a nutritional intervention along with a low dose of dialysis. Now, we all know that starting off dialysis at any age is definitely going to prolong the survival, but especially in the elderly, there is definitely a reduction in the quality of life. It lowers the functional status, because this patient then becomes dependent on dialysis 3 times a week, 4 times a week. They have to go to the dialysis unit, and it also, affects the interpersonal relationships, their social life, and it may also have an impact on the financial status, given to consider that, yes, we come from a low resource setting country. So these are things which specifically need to be looked after in the elderly. So what we can along with that, starting the dialysis itself, and CKD by itself may, make these patients suffer from something that's called as the MIA or the MIA syndrome, which includes malnutrition, inflammation, and accelerated atherosclerosis. So a strategy which can help to solve both these dilemmas, that is, you give them a good quality of life and relieve them of the uremic toxins, both of it together can be achieved by combination of nutritional intervention along with a low dose of dialysis. So the integrated program, which can be used in these patients, is a very low protein diet, that's around 0.3 to 0.4 grams of proteins per day, supplemented with a mixture of essential amino acids and keto acids for 6 days a week. You give them a strict sodium and water restriction, and you give them 1 or 2 hemodialysis sessions per week with an unrestricted diet on the dialysis day. Now, an ideal case scenario would be that the patient is offered a low dose peritoneal dialysis, which is a lot more physiological, less invasive, can be a home based therapy, and much better tolerated in these patients who may have a higher incidence of underlying cardiovascular disease. Now, whereas the combination strategy sounds very good theoretically, to a large extent in our country, it may not be possible, because this requires a very, very, very close follow-up with your clinician and your dietitian. And knowing the Indian mindset, essentially, that, once they start feeling better, the follow-ups become delayed, and obviously the fact that these are not insurance policy covered strategies, the financial issues also become a point. They are not very commonly used in our country, but yes, there is enough data that says that they can be successfully used, especially in the elderly. Now, the advantages of this are that, yes, on one side, the metabolic components, clinical symptoms of volume overload, and you maintain your residual renal function, and obviously the patient is more functional emotionally, more functional physically. He doesn't have to keep visiting the hospitals, and to a very large extent, there is a lot of dignity in which is preserved, and obviously the direct, indirect, the financial aspects of what I spoke is it works out better. But as I said, the concerns are that it requires a very, very strict therapeutic regimen with, and the diet becomes very unpalatable to a very large extent. And these are the patients who may, kind of tip over to malnutrition, and therefore requires a very strict monitoring with a multidisciplinary team with a dedicated renal dietitian. And it may also require the help of the family and the caregivers who are going to take responsibility of the entire strategy, which may be difficult on some occasions. Now, what are the nutritional interventions which can be done? So the basic aim of the nutritional intervention would be that you tackle the age-related causes, you tackle the psychosocial and the medical issues that are associated with these patients, and you counteract the dialysis-related, the specific dialysis-related problems that would come, like the uremic toxicity or the metabolic derangements, and the, as I said, the MIA syndrome. So you tackle those also, so that you kind of intervene for the acute and the chronic long-term complications that these patients would specifically have. So if we say that we have the intervention of the age-related, so as I said, the common age-related, like the chewing, the swallowing, they have atrophic gastritis, they may have malabsorptions. So there have been a lot of studies which say that we can add the oral nutritional supplements to the regular diet, and beta-hydroxyl beta-methyl butyrate is the most commonly studied supplement as of now. And of course, we make sure that they have their vitamin D supplements, their calcium supplements, and a very dedicated team of physiotherapy and rehabilitation for these patients, especially during the time of dialysis, would help in tackling the age-related problems like sarcopenia or the protein energy wasting that is seen with age. Now, we have to remember that all of these are being extrapolated from the data which is given to us for elderly patients with non-renal diseases. We do not at present have specified trials or protocols or robust data that is going to help us for these interventions in patients with renal diseases. And this is the need of the time right now. The various psychosocial and medical causes, the medical treatment of dementia and depression, and the psychiatrist needs to be involved. There is a large body of data which says that homocysteine supplements in these patients help them overcome a lot of psychosocial issues. There are large trials which say that socialization and group therapy, so eating together and not allowing them to eat alone or with friends, or eating in the dialysis centers or eating with other patients or with the family, does increase their oral intake significantly. And there are a lot of modifiable risk factors for cognitive decline which need to be worked with. And this is where you would require the help of a psychiatrist or the psychological counseling in these patients. The interventions related to the dialysis related causes. So, you try giving them a snack during dialysis, because then you are sure that they have eaten whatever they were supposed to, or their nutritional requirements have been met with in a directly observed way. And we may also add the oral nutritional supplements during dialysis, so provided during the session. So again, you're ensuring that you have it. And there is a large body of work which says that especially for the frail and especially for those who have the protein energy wasting, intradialytic parenteral nutrition intermittently will help them to get over, because we need to remember a well-fed or a nourished, or maybe to even a large extent, I may use the word, a obese patient on dialysis does significantly well as compared to a malnourished or a frail patient on dialysis. And there is enough data today to suggest that these patients do worse as compared to a obese patient. So essentially, I'm going to end my talk with the next few messages, which will be my take-home messages, that we need to realize that elderly patients, irrespective of their renal status, are more frail, and with the renal disease are at a higher risk of impaired nutritional status. We need to have a regular monitoring for their nutritional status, including their nutritional intake, the risk factors which are associated with aging and kidney disease, so that we discover these nutritional impairment early and we can intervene at the right time. We need a multifaceted approach, and it can't be just a dialysis technician or just a dialysis nurse or just a nephrologist looking after this, because we have many factors that need to be looked after apart from just diagnosing the protein energy wasting. So including managing the food preparation, the cognitive dysfunction associated, the depression, and the social integration in these patients. We may try and use the safe strategy. We don't have a choice here. So we have to include and ensure that the patient has a high energy intake, a 30 to 35 kilocalories per kg per day intake, before we actually initiate the dietary restrictions of protein, salt, and other micronutrients like phosphorus, because a patient who does not have this will eventually lead to negative nitrogen balance and severe protein energy wasting. Lastly, combination therapy, that is nutritional intervention with low dose dialysis, is a novel therapy for the elderly, which has to be thought about and practiced, obviously with a multi-team approach. So I end my talk here, and I'll be happy to take any questions.
Yeah, but unfortunately, somebody has to sacrifice, and because the first talk took a little longer time, Mayuri, since you're part of the organizing committee, you'll have to sacrifice.
Absolutely, sir. The pleasure will be mine. Thank you very much.
Yes. Harisha, just your closing comments. And then
yes, sir. Dr. Mayuri, that was an exhaustive and very insightful talk regarding the nutritional challenges of in elderly patient. Thank you very much.
Thank you, Dr. Mayuri, and thank you, chairpersons. Now moving on to the next talk, which is nutrition in the palliative care. And we are all aware that not just comfort of symptoms, but also nutrition plays a very vital role. So for the next talk, I would invite chairpersons, Dr. Kiran Kumar Mukku, who is a nephrologist and renal transplant physician with Continental Hospitals, Hyderabad. Dr. Ravindra Prabhu, who is the professor of nephrology at Kasturba Medical College, Manipal, and Safala Mahadik ma'am, she is a senior dietitian of KEM Hospital, Mumbai.
Good afternoon.
Good afternoon. And I'm very happy to be, I would like to thank organizing committee for inviting me here today to chair this session. Thank you so much. Who's that? This thing? Smriti, should I introduce her? Sir?
Please introduce.
Yeah.
Otherwise, I have to introduce, and she's my daughter, so I cannot introduce.
Oh, sorry, sir. Yeah, I'll be really glad to introduce Smriti Khanna. She's a consultant at Sparsh Clinic, Mumbai, and she's consultant pediatric palliative and supportive care unit at BJ Wadia Hospital for Children. And her special interest in pediatric palliative care, non-oncology palliative care, and medical ethics. So I would really appreciate now. Please start with Smriti Khanna for your over to you, Smriti, for this session.
Dr. Smriti, can you unmute yourself? Yes.
Thank you, ma'am, and thank you, Srnmcon, for this wonderful opportunity. I'd like to go straight into my presentation. So I'm going to be talking about today on nutrition in palliative care. And this will be focused on mainly on renal palliative care and patients who have renal disease. Let's start by discussing what palliative care actually means. So in a nutshell, palliative care is care that improves the quality of life of any patient who has a life-limiting illness. Now, that could be a patient with cancer, that could be a patient with a non-oncological condition, and sorry, just a second. That could be a patient with cancer, that could be a patient with a non-oncological condition, that could be a patient with any end organ failure, and end organ and end-stage kidney disease is part of that. So what all do we do in palliative care? Basically, we provide symptom relief, caregiver support. We try to see how to manage the patient at home, and we do end-of-life care, we do counseling. And in effect, what palliative care does is it brings a lot of streams together. It brings like a multidisciplinary team together to provide the additional supportive care that a patient with renal disease might need. Now, this could include nursing, this could include physiotherapy, this could include dietitian, and this could include occupational therapy, whether it is counseling. All these things are part of the services that palliative care provides. So with respect to this talk, what are the patients who might need palliative care? And some of the patients who may need it are elderly individuals with renal failure, in which who are frail, who have decided not to go ahead with dialysis, who have multiple complications that is hindering dialysis for them. Patients with multi-organ failure, in which renal failure is one of it, and who have considerable morbidity as a result of it. Patients who have multiple dialysis associated complications and not be possible for them.
I think there is a voice problem.
Yes, it's not audible. Yeah.
Okay, just a minute.
Now you're audible.
Okay.
It was momentary.
Okay. Right. So patients with dialysis-associated complications, patients who have refused dialysis, and patients who have renal failure combined with other illnesses. This may be heart disease, stroke, bedridden patients, cancers, etc. I'd also like to introduce the concept of renal supportive care, which is something that is making a lot of headlines nowadays amongst palliative care and nephrology circles. Who are the patients who will receive renal supportive care? So these may be patients who are being managed on a non-dialysis pathway, who have kidney disease, or they could be dialysis-dependent patients with a high symptom burden. So the point to note here is that it's not that these patients, the patients on renal supportive care may have necessarily refused dialysis or may not be able to undergo dialysis. Even dialysis-dependent patients with multiple symptoms, which need close follow-up, which need a lot of medications, all these can avail of renal supportive care. Some concepts which are slightly different in renal supportive care is that it's predominantly patient-centered. The focus is more on improving the quality of life on the physical symptoms that the patients might have, and listening to patient preferences and adapting the care they receive according to that. So in a way, it's a kind of specialized care. Also, renal supportive care has a lot of teamwork involved in it. So usually there will be the nephrologist, there will be the palliative care physician or the renal supportive care physician, there will be nursing staff, there will be physiotherapy, dietetics, all of these will come together. So when it comes to nutrition in renal supportive care or in palliative care, we're talking about both of them together now. Where do we start? It's important to first identify what goals of care are for this individual. Do they mean to continue with dialysis? Do they mean to, would they like to stay at home with their family? Would they like to be able to travel? Would they want to have as much of independence in their life and in their physical activities as much as possible? Here is where we begin to understand what the patient wants, and then we communicate with the family. We talk about the patient's likes and dislikes. This could be in the broader sense, and this could also mean talking about their nutritional preferences. Do they have special nutrition needs, like, for example, children or patients with concomitant nutritional issues? Also, in patients like these, we may need to elicit preferences on enteral and parenteral nutrition. It may not be for that point of time, it may be for a time in the future, because especially for patients with multi-system or multi-organ diseases, or patients with neurological illnesses along with kidney failure, where there is a chance that they might lose competence in the future, it's important for us to know what they feel about getting enteral or parenteral nutrition. So this table talks about dietary requirements of CKD in renal supportive, CKD patients on renal supportive care, and comparing it with patients with CKD, patients on hemodialysis, patients on peritoneal dialysis. Now, if you see, there are quite specific requirements for patients on hemodialysis, patients on peritoneal dialysis, or even in the general CKD area, with respect to energy, potassium, sodium, all of these. But if you look at the CKD RSC bit, the only thing that is really sort of mandated is the protein requirement, and that too, it says later on in the table that it is quite flexible, because a lot of this is going to be individualized based on their nutritional status, based on their preferences, based on how their physical functions are. So we may have to see patients who are bedridden with chronic kidney disease, or you may have a patient who is fully active with chronic kidney disease, and their energy requirements are going to be very different. When it comes to serum potassium, this is something which is important because hyperkalemia can lead to acute problems for the patient. But if we're looking at things like phosphate and monitoring phosphate levels, making sure that diet requirements are in place for them, in some patients on palliative care, they may not have the amount of lifespan left, where we are looking for the long-term consequences of hyperphosphatemia, where we're looking for bone changes in them. So we are not always thinking of 10 years down the line or 5 years down the line. The main problem, the main issues in dietary requirements in palliative care patients comes mainly with regards to sodium, potassium, and fluid. Sodium and fluid, because this is something that is going to cause fluid retention, that is going to affect their breathlessness, and that is a symptom that we are looking to control, especially if they are not going to be on dialysis. So those restrictions may need to be made in order, because they directly impact the symptoms of the patient. Sorry, I can't see before. Just a minute. Could somebody let me stop sharing, please?
Somebody from M&M? Yeah.
Thank you. Now, what are the problems or rather the symptoms that we encounter in patients with CKD? There is nausea, anorexia, cachexia. Some of them may be on RT feeds. There will be fluid overload. They might have intestinal obstruction. They may have change of taste. And when we are looking at it from a renal supportive care point of view, many patients will complain that they have too many restrictions on their diet. Now, how can we look at these problems from a diet point of view and try to change them and try to make them better? Patients who have nausea, we could try giving them bland foods. We could try to avoid skipping meals because that will aggravate the nausea. Avoid strong smells because that will make them not want to eat sometimes. Ginger and ginger products, whether it is ginger tea or crystallized ginger, these things can help with the nausea. With anorexia, small meals, reducing their fiber intake so that they do not feel bloated, encouraging snacking, encouraging finger foods, and varying the texture and flavor of the foods that they are taking. For patients with cachexia, high nutrition meals might help. For those who have change of taste or a bitter taste in their mouth, soda bicarb mouthwashes. All you need to do is take 1 teaspoon of normal cooking soda in half a glass of water and gargle 4 times a day, in half a liter of water, sorry. Encouraging use of herbs and spices. Cold foods and drink, these can help with patients who struggle with change of taste. Patients with fluid overload, we will look for sodium and water restriction for them. Those who have dry mouth, sour candy or lemons, rinsing their mouth regularly, mouthwashes. And when it comes to constipation, we look at a high fiber diet or fiber supplements and also look at physical activity. Now, when it comes to too many restrictions, through the lens of palliative care, a palliative care physician would be telling you that restrict only if it impacts the symptoms and do not look at patients at the problems that might happen 10 years down the line or 5 years down the line. So these are some SAQs I'm sure that we all must be hearing. He doesn't eat anything. Can I give her protein powders? In here, we also have to consider the psychological aspect, the social aspect of the patient, of the family. Is there anything else they're trying to say? Are they trying to communicate their worry more than anything? And so over here, this is where the power of counseling comes in. And everybody, I think, can work as a counselor as part of their daily job, whether it is a doctor, whether it is a dietitian, whether it is a nurse. Everybody has the ability to listen to the patient, listen to their worries. And through that, we may be able to help them just allay their worries a little bit. When we talk about nutrition at the end of life, we are thinking about the final weeks of life. What physiological changes will occur at this point of time? There will be a reduced desire to eat. Patients will not want to eat. There will be a reduced physiological need for nutrition. So this is where families panic. Feeding is something that is so important to families, to loved ones. But as a dietitian or as a member of their medical team, it is important for us to talk to them about the importance of comfort here rather than nutrition. Because we are looking at the final few days or weeks of life, all we're trying to do is to keep them comfortable. So we avoid force feeding, avoid forcing them to eat. All we do is prioritize enjoyment of their foods. So what it is that we could just make a few things that they like. And even if they just have a spoon or two of that particular meal, that's fine, because all we're trying to do is to help them enjoy whatever their favorite food was. And it's important to reassure families because they will be very worried about the fact that their food intake has drastically come down. So talking to them in a way to say that his or her requirement for food, for nutrition has reduced. And he does not require as much nutrition as he used to previously. And it's we need to respect that. We need to not force feed them. So some food of thought before we move to our take-home messages. When we look at patients who require palliative care, we think more about their short-term implications. We think more about how this will impact their symptoms today, tomorrow, or a few days down the line. We don't worry as much about long-term implications. We don't think about what this will mean to them a few years down the line. As the speaker prior to me has also spoken about this, the social aspects of eating, being there with the family at the table while food is being served, that might encourage them to eat. Just the simple act of sitting at the table with the family, or sitting at the table at a party with friends over, these things might encourage them to eat. I would also encourage you to think about how families would appreciate a rationale for dietary advice, and especially when dietary advice is changing. If we are thinking about changing goals of care from a therapeutic to a palliative pathway, how they would appreciate the fact that we are changing their nutrition goals accordingly. And then think about, what does food mean in our society, in a family life? It means love, it means care, it means bringing the family together. And so food really has so many other implications apart from nutrition. Then we can think of the physical function and the psychological status. How does it impact appetite of a person? A patient who is depressed, would they be able to eat as much as possible? A patient who is sedentary as compared to one who is mobile, how will that impact their appetite? Somebody who has suddenly become bedridden, what will that mean for them? So I think I would like to finish just with some take-home points. It's important to be flexible in these patients and communicate exactly what it is that we plan to do, and more importantly, what it is that is in their minds. Restrictions only if they impact the patient's physical or psychological well-being. This can include psychological factors, and this can include their symptoms. Following up to assess comfort with their dietary plans, and to support patients as dietary restrictions are changed. What most patients on palliative care feel is an abandonment by the medical system. They feel that their doctors have abandoned them, their hospital has abandoned them. They've just told them to stay at home. And that is not true. We need to explain to them that these dietary restrictions are part of the medical care that we are giving them. Remember that renal supportive care is patient-centered, and that you are part of their journey and not vice versa. And I'd like to end with this quote from Atul Gawande, that we think that it is our job to ensure survival, but more than that, really, it is to enable well-being. Thank you.
Thank you, Dr. Smriti. I would like to really congratulate you for such an excellent and very self-explanatory talk. I'm sure there will be no questions about this care, because you appropriately addressed all the factors related to palliative care. Thank you so much.
I think, Ravindra, you have done a lot of work in palliative. Any comments from your side?
First of all, thank you, sir, for bringing me on as a chairperson here. And it was a very nice overview by Dr. Smriti, where she told us about the palliative care and especially about the nutrition. As you told, we have just started our renal supportive care, trying to integrate it into the kidney side. As of now, it's we know very well that it's a very cancer-centric kind of field, and slowly it has to be integrated. And the kidney patients really face some symptom burden and morbidities which are equal to cancer itself. So our field is really ripe for this kind of organized, conservative, supportive care. Some of the differences would be that we should not be like islands, that the person who should give up dialysis totally and then go for this thing, which it should be complementary. The person who is on dialysis also can receive supportive care. This we should understand. And also that end of life, when we identify somebody who's at the end of life who cannot have the dialysis, such people we need to really identify. And if we can put them on to this kind of care modules, the last few days of their life, they need not spend unnecessarily in acute care settings, in ICUs, away from their relations, and they can have a more dignified end. That is, if it is well planned. This is what we are slowly learning in our own unit, and I think this training should be given to our residents and registrars also. And some of the points about the nutrition also she brought out very well, in the form that the nutrition should be liberalized, especially in the last few days of life. We cannot be very rigid about the diet. The person should be allowed to take some of the things he would have liked to do. And also, again, it's a challenge that to have a good, to give nutrition, to have a good quality of life, at the same time avoiding dialysis. So this is the thing. Again, I would like to thank you and compliment her for a good talk.
I think Kiran Kumar hasn't spoken. Kiran, you can end the talk.
Yes, sir. First of all, I would like to thank Dr. Umesh Khanna for giving me this chance to be a chairperson for this session. And I mean, a very good and crisp presentation by Dr. Smriti Khanna. There are a lot of congratulatory messages on the chat box for Dr. Smriti Khanna. So if there are no other questions, I would like to close the session and move forward to the next question. Next.
Thank you.
Yeah.
Thank you. I think the anchor can take over.
Thank you, Dr. Smriti, for the excellent talk, and thank you, respected chairpersons. Now, moving to the next talk is nutrition in patients with kidney and liver disease. For this talk, I would like to invite the chairpersons, Dr. Srnmcon Sundaran sir. He's the consultant of nephrology and transplant. He's the head of international transplant services at Manipal Hospital, Bangalore. Dr. Arvind Conjeevaram, he is a consultant nephrology and transplant physician at the Bangalore, Sagar and Trustwell hospitals, as well as he is a co-founder at Bloom Value Corporation. And Ritu Sudhakar, she is the chief dietitian of Dayanand Medical College and Hospital, Ludhiana. Over to you, chairperson.
Thank you. An excellent session ongoing at the Srnmcon 2021. It is my duty to introduce Dr. Narayan Prasad. Quite frankly, he needs no introduction. He's professor and head of Department of Nephrology at the Sanjay Gandhi Postgraduate Institute of Medical Sciences. He's the honorary secretary of the Indian Society of Nephrology, deputy chair of the South Asia Regional Board, and so on and so forth. He's going to speak on the special populations of patients with kidney and liver disease. Following that, the Q&A session will be taken up by Dr. Sundar and Ritu Sudhakar. Over to Dr. Narayan Prasad.
My slide visible?
Yes.
Yes.
Okay.
Yes.
Go ahead, Narayan. Go ahead. We can hear you.
At the outset, I would like to thank the organizing committee, Dr. Umesh Khanna, sir, and the chairman of this special session, Dr. Arvind Kachi, Dr. Sundar, and Dr. Ritu. And a special thank to Dr. Arvind for this special introduction. Thank you very much. So today's topic is patient with a kidney and liver disease. And, this is a nutrition in a special situation kind of topics. So one of the nephrologists is going to talk about nutrition problem with liver disease. If the patient simultaneously might have the chronic kidney disease or any kidney disease. So I'm starting this with the two photographs. The one of the patient with a chronic liver disease. Here we can see the protruded abdomen with lot of ascites, prominent veins. So it itself is speaking that patient is probably suffering from chronic liver disease. Here is another patient who is on dialysis. Here you can see the patient has ascites. Both are looking malnourished. There is no confusion. By look, you can say both patients are malnourished. And this kind of the physical examination with the protruded umbilicus here we can see is known for 300, known since 300 to 900 C without one of the photographs here in Mayan usual sites on the island of Java. So this is a well-known condition. So what are the similarity in both the condition in CKD and CLD? That we need to understand. Similarity between the two conditions both are end-stage organ damage. Malnutrition is very common in both. Sarcopenia is very common in both, liver more than the kidney. Carbohydrate and fat calorie requirement is there in both categories. Protein requirement is approximately the same in the both, except when the patient has hepatic encephalopathy. Sodium intake requirement in the both conditions looking like they should be on the lower sodium diet. Micronutrient requirements are also seen. So both conditions sometimes have a similar kind of situation, and then you have to adjust the diet. Looking at the prevalence of malnutrition, particularly protein energy malnutrition in CKD patient, you all understand 60% patient had mild to moderate malnutrition and 10% had severe malnutrition. And the similar percentage of the patient in the chronic liver disease also. Approximately 65 to 90% of the patient with advanced chronic liver disease has malnutrition. This is our own study, which we have published a few years before, one in 2008, another in 2016, where we have seen that mild to moderate malnutrition based on the subjective global assessment is 68%, and 7% patient can have severe malnutrition when the patient are going for dialysis. So coming to the situation where in the liver disease, liver, we all understand, is a larger organ than this kidney, but God has given us the two kidneys, but one liver. Probably kidney looking like more important. But when you have the both liver and kidney affected, you can think of the condition of a patient. Liver, this is a storage for the glycogen, a source of the energy. Fat in form of the lipoprotein and triglyceride. They synthesize albumin, one of the very important nutritional components. They detoxify, they produce biles, but the patient with a liver disease are very much malnourished because of the multiple problems, because of the loss of appetite and inadequate intake, impaired digestion, impaired absorption, and altered metabolism, as well as the liver is the site of metabolism of most of the nutrients. So cirrhosis represents an accelerated state of the starvation that is called hypermetabolism. There is loss of protein, decreased synthesis of the urea and hepatic proteins, decreased intestinal protein absorption, but at the same time there is increase in urinary nitrogenous excretion. So you can think of when your kidney is also went off, this will go on accumulating, and there is a lower ratio of branched chain amino acid as compared to aromatic amino acids. Abnormal carbohydrate metabolisms, insulin resistance, impaired gluconeogenesis, reduced glycogen storage, and the lipids are preferably oxidized here in this condition for the energy. So amino acids which are altered in liver disease, here we can see there are few amino acids like the aromatic amino acids are increased, tyrosine, phenylalanine, and tryptophan. Most important, which is one of the protein which is in real sense promoted for the increased use day-to-day practice, is the branched chain amino acid that contain leucine, isoleucine, and valine. Their levels are actually decreased, and this amino acid component is very important for muscle building. And if there is a deficit, there is high chance of the patient would be sarcopenia. Other amino acids levels are also increased. So we have to focus on the branched chain amino acid. The levels are very much decreased, and that is associated with the very much malnutrition and sarcopenia. So how to link this muscle, chronic liver disease, and CKD metabolisms? Decreased level of the hepatic and muscle glycogen storage are very common in liver disease that lead to reduced availability of glucose as the energy substrate, which results in increased consumption of the fat and protein. So gradually, if you have less storage of the glycogen, your fat and proteins consumption go up, and you would be deficit in fat and proteins also. Muscle is a major metabolic organ and has an essential role in amino acid metabolism and production of nitric acid. Kidney plays a role in elimination of the nitrogenous product that we all understand in the form of urea and creatinine. But it is a site of the gluconeogenesis also, particularly when you have less glycogen stored. This gluconeogenesis from the kidney component go up. But when the kidney is also failed, then you can think of gluconeogenesis will go down. And the process of gluconeogenesis leads to muscle destruction as a source of protein substrate, and protein synthesis decrease. So this process of gluconeogenesis, actually, ultimately they use protein substrate when there is only the liver failure. And protein as a substrate for the gluconeogenesis, and ultimately leads to protein deficit state. Hepatic encephalopathy is more frequent in malnourished individual, and thus cirrhotic patients with sarcopenia have increased risk of hepatic encephalopathy. About 34% of the patients have a rest energy expenditure, REE, of 120% above the expected value. So resting energy expenditure is very high. Up to 70% of the cirrhotic patients, glucose intolerance or insulin resistance, and between 10 and 40% have type 2 diabetes mellitus also. So type 2 diabetes incidence is also very high. Decreased level of the hepatic and muscle glycogen are also common, leading to reduced availability of glucose as energy substrate, which results in increased consumption of the fat and protein, as I have already explained. So sarcopenia and cirrhosis, there are multiple reasons. It is very common condition associated with chronic liver disease, inadequate dietary intake, which you can see a lot of problems associated with this decreased dietary intake, metabolic disturbances and malabsorption, that is very common features we all understand associated with chronic liver disease. Respiratory quotient, reduction in respiratory quotient is very much common in the cirrhotic patient as compared to control. Here we can see, and resting energy expenditure is very high with the cirrhotics as compared to control. This is well established condition in chronic liver disease. So nutritional supplement in sarcopenia. Suppose the patient is sarcopenia, patient has chronic liver disease. Nutritional counseling and multidisciplinary approach is very much required. Energy intake here, 35 kilocalorie per kilogram body weight. Protein intake is 1.2 to 1.5 gram per day. We'll discuss this part later on in accordance with the other condition also. Decompensated cirrhosis, poor protein intake, particularly branch chain amino acid supplements and leucine-rich oral supplements are usually required, particularly to support this sarcopenia. Role of branch chain amino acids, plasma level of this branch chain amino acid correlating the serum albumin and increasing cirrhosis. Promotes protein synthesis in muscles. In the liver, stimulates secretion of hepatocyte growth factor by hepatic stellate cells. Coming to our kidney part. Here we can see we are all aware, we might have discussed several times, there are 5 stages of the chronic kidney disease. Early chronic kidney disease, stage 1 to 4. Stage 5 to the patient who required hemodialysis. Stage 5, peritoneal dialysis patient. Here we can see calorie requirement. Almost 30 to 35 kilocalorie per kilogram body weight up to stage 4. You have to be on the higher side, more than 30, 35 kilocalorie per kilogram on patient on dialysis or peritoneal dialysis. Protein intake requirement in patients on hemodialysis go up. That we all understand. I'm not going to spend too much of the time here. Here, what we can see here about the requirement of the sodium, that should not go more than 2 grams at any stage, whether this is the early stages of the CKD, hemodialysis or peritoneal dialysis. Potassium intake should not go more than 2 to 3 grams. If the patient on peritoneal dialysis, they have a little bit more liberty to take up potassium containing food, like 3 to 4 grams as compared to 2 to 3 grams patient on hemodialysis. Phosphorus, that is one of the important components always in practice of nephrologists. Here we can see stage 5, 800 to 1 gram. Again, in peritoneal dialysis, 800 to 1 gram is charged. And how we will take care of this phosphorus, things we'll discuss later on. So in terms of the calorie intake, what we understand that the calorie intake should be sufficient in any patients on the dialysis, whether this patient is on dialysis or off dialysis. What we can see, our own study has shown that was a very alarming thing which we have studied about in 2008 about more than 200 patients. Calorie intake in the patients with this here we can see severe malnourished patient has only 13 kilocalorie per kilogram body weight, and mild to moderate malnutrition has 17.8 kilocalorie per kilogram body weight. So calorie intake is very challenging, and that also remains because of the loss of appetite. The reason might be anything, inadequate dialysis or anything else, but calorie intake in our group of the patients was very low. So that we must ensure as a dietitian or as in our practice. Inadequate energy intake is essential to optimize nutritional status. Calculated based on your current weight, current loss goals, age and gender, physical activity. So calorie we have already talked about. 65 to 70% of the total calories would be with particularly the carbohydrates would be 70% complex sugar and 30% should be simple sugar. But always keep in mind whether you are giving these prescriptions to diabetics and whether your target you are able to achieve the glycosylated hemoglobin of less than 7%. Protein intake, we all understand, we talked about the early stages up to this 0.6 to 0.7 gram per kilogram body weight. Stage 5, you have to increase 1.2 to 1.3 gram per kilogram body weight. All stages, if patients are malnourished, where we have to focus, where is the responsibility of this dietitians or nephrologists? Many of the patients are in malnourished state at the early stages of the chronic kidney disease, and restriction of this protein might be problematic for the patient. So at all stages, if malnourished, give them the additional protein, at least to combat this protein malnutrition. So protein should not be restricted in patients with a liver disease unless they become protein intolerant due to hepatic encephalopathy. We all understand giving too much of the protein increased formation of the ammonia and encephalopathy may worsen. But with the fully compensated chronic liver disease, there is no restriction of the protein. And until unless the patient is in hepatic encephalopathy, and protein intake recommended is somewhat similar to the chronic kidney disease patients on dialysis, 1 to 1.5 gram per kilogram body weight. Several studies have shown that daily protein supply of 1 to 1.2 gram per kilogram per day may be sufficient to prevent negative nitrogen balance in cirrhosis. With mild stress, you have to increase a little bit towards the higher side of 1.5 gram per kilogram per day. And with acute exacerbation of hepatitis and decompensation, sometimes you might require to little bit increase depending upon the status of hepatic encephalopathy. One thing is very much common that it is thought that majority of the patients on the cirrhosis, as a nephrologist, we should be aware that they are on the propranolol or other beta blockers. And beta blockers increase protein oxidation, an alternative method of the protein metabolism without energy production, and may increase protein requirement. And patient on propranolol should be placed on the higher end of the protein intake. That is one practicing point. Lipids in the diet, again, where you can see when you are not able to give too much of the protein in the diet, you have to meet the calorie requirement. So calorie requirement can be met with increase in the diet by the fat. 30% of the total calories should be given through this fat. Minimize, there is increase in triglyceride and cholesterol. Less than 10% of the calorie, saturated fatty acids should be there. Otherwise, unsaturated fatty acids are before over this saturated fatty acid in total calorie calculations. Sodium and fluids are another important point that we have already understood. One of the important points for the nephrologists and those dietitians who are dealing with the patients on the dialysis, interdialytic weight gain. General recommendation is there that between the two dialysis should not be more than 2 kg of the weight gain. More than 5% of the fluid gains, we must think whether your patient is taking excessive fluid or weight gain is too much, then, or whether your patient is taking too much of the salt. Salt is more important than your fluid intake. If your patient is taking too much of the salt, they are retaining more fluid. they would be more thirsty. So whether you have to ensure that the patient's salt intake is high. Less than 2% fluid, then inadequate fluid or food intake. Whether even if your fluid gain is not much, but patient is malnourished, whether really your patient is taking well on. So at all point of the time, we can see here the sodium intake should not be more than 2 to 3 grams. If the anuric patient, only 2 grams will be suffice. Phosphorus balance is again another important factors. Diet plus binders plus adequate dialysis. There are 3 important things. So dietary restrictions, but if you meet the demand of the protein in patients on the dialysis, you have to give the protein diet. But that needs to be controlled. That should be within the limit. So absorption approximately plus 600 milligram per day, binding by 50% and dialysis removal by 50%. So 50% can be removed with this binder and 50% can be dialysis can remove, and accordingly you have to balance the weekly phosphorus intake. So we have to understand that how much dialysis, whether the patient is getting adequate dialysis or not, whether the phosphorus balance is there, because these are few things which are directly associated with the cardiovascular mortality patients on chronic kidney disease, patient of chronic kidney disease. Vitamins and macronutrients, B complex, vitamin B1, B6, B9, and B12 deficiency are common. Trace elements, I would like to little bit emphasize the zinc level are reduced and play a role in the pathogenesis of hepatic encephalopathy particularly. Selenium deficiency, severity of the hepatic fibrosis in hepatitis C and contributing to insulin resistance. Manganese level, magnesium is one thing which is very important for us, but we should also understand about the manganese levels. Magnesium hypermagnesemia is very common in patients on dialysis, and sometimes hypomagnesemia also associated. But manganese level increases, get accumulated in the basal ganglia and plays a role in the pathogenesis of hepatic encephalopathy. So manganese intake should be always towards the lower side. That we should always understand if the patient has coexisting CLD. So nutrition in hepatic encephalopathy, EASLA recommendation for the calorie intake, we can see here 35 kilocalorie, avoid protein restrictions, branch chain amino acid supplementation should be considered. Oral would improve the neurocyclic performance and to reach the recommended nitrogen intake. Oral dietary intake is preferred. Grade 3 and 4 encephalopathy, they can be given feed with the nasogastric tubes. Drug nutrient interaction is another important aspect for the nephrologist who practice on such patients with the chronic liver disease. Most diuretics leads to loss of the potassium, magnesium, and zinc. That we should understand when the patient is on diuretics. Spironolactone retains potassium. That we all understand. So when there is habit of writing this diuretics plus spironolactone by gastromedicine colleague, but we should think of whether your patient's potassium balance in patient with a renal failure is adequate or not. Cholestyramine results in the loss of the vitamin A, D, E, and K by binding salts. Prolonged neomycin use can cause bilious atrophy, leading to loss of the zinc and increased incidence of diarrhea. Aminoglycosides results in increased loss of the potassium, magnesium, and calcium due to altered excretion. Beta blockers increases the protein oxidation and increase the dietary protein requirements. So recommendation for the macronutrient deficiency in cirrhosis, administer macronutrients or vitamins in clinically suspected and confirmed deficiency. Vitamin D levels is another important thing. Hepatic osteodystrophy, particularly osteoporosis is very common in patients with a chronic liver disease, and renal osteodystrophy is also very common in patients with a chronic kidney disease. And vitamin D deficiency is very common even in the general population, in a special population like the patients of chronic kidney disease. So we should always assess whether your vitamin D level of your patients are good or not. If they are not in adequate amount, we should try to supplement it. So macronutrient in critically ill cirrhotic patients, calorie requirement we have already spoken. If they are very critically sick cirrhotic patient, may require higher, more than 35 to 40 kilocalorie per per kilogram or 1.3 times measured resting energy expenditure. Total protein intake should be 1.2 to 1.3 gram per kilogram. Branch chain amino acid enriched immune enhancing diet should be there. And one thing in the last, but not the least, we should understand there are several recommendations comes about giving the testosterone if the patient is sarcopenic, they are too weak. Give them growth hormones. Other myostatin antagonist. So, but roles are limited and they are shown to be associated with the enhanced incidence of hepatocellular carcinoma. Should always be aware that this is not always a helpful therapy. So take home message, individualization of the calorie, protein, fat, and salt intake is important in clinical practice. One size does not fit in all. So it is very much important to individualize your prescription of the calorie, protein, fat, and salt intake for each patient. CLD and CKD, and sometimes hepatorenal syndrome and AKI coexist and make it further complex. Help of the trained dietitians may be helpful to optimize the nutritional intervention in such cases. Thank you, ladies and gentlemen. Thank you for your kind attention and for this opportunity. Over to you, Dr. Arvind and Professor Sundar sir.
Yeah. Thank you, Umesh. Thank you, Umesh, for giving me a chance to chair this important session. As Arvind rightly said, Narayan, you've done a great job. It's a very complicated topic, even to analyze somebody having liver and kidney failure in our day-to-day practice. It's not easy. Kidney alone is giving diet advice is not easy. Having liver problem with kidney disease is more difficult. And I wish, Ritu, are you available? I would like you to take over because you are important in this session. If you're there, please take over and give your comments, please, Ritu.
Yeah. Thank you, Dr. Narayan. It was actually a very brilliant talk, and you so very, rightly emphasized the importance of calories, energy, along with protein, right amount of protein and fat. So, because in my clinical practice, even I feel so that when we come across patients of liver disease with CKD, it's very difficult as to decide what they actually need, to be able to give them the right kind of nutrition. Before I move over to the questions by the audience, I personally have one query. Like you emphasize the role of right? So during encephalopathy, but most branch chain amino acid preparations for oral use or feeding tube, they come loaded with potassium. So what do we do in such a case?
Actually, when you have a patient of the liver disease alone, so then there is no problem because we have to avoid the potassium, avoid hypokalemia. Right. Hypokalemia actually precipitates hepatic encephalopathy. So there you have to balance actually the potassium level. So avoid hypokalemia in patient of the chronic liver disease, particularly patient prone for developing hepatic encephalopathy. So in that situation, there we should always take the precautions. But when it is associated with the chronic kidney disease or end-stage renal disease, where potassium is always a problem, and hyperkalemia might be associated.
So
that's why I have given
इसके नीचे दो लाइन आ जाएंगी वो आपको introduce करें.
So that's why I have given the emphasis that potassium should always in the mind.
And is उसमें आ जाएगा junior consultant at Hindu Hospital, Dr. Alan.
Can all the participants mute themselves, please? Yeah. Okay. And sir, another question that I have as a dietitian, like if it's we have to choose between protecting liver and kidney, is it that, whom to give preference first?
I think being a nephrologist, we prefer kidney. We are biased towards kidney. What is it, Narayan?
I have already told in the beginning that the God has given you the two kidneys because they might have thought that kidneys are more important than the liver. And the liver cells usually grow by automatically, but kidney cells do not grow. So,
but I don't know. At least we have kidney problem, you have got dialysis. Whereas liver, you don't have that option.
So this is joke apart. Actually, what is there that you have to think of the expectancy of the life because of this organ damage. Suppose if the patient, both are the condition having this end-stage organ damage. If chronic liver disease is such a cirrhosis is such a severe condition, when you are not expecting the patient is going to live more than 1 year or one kind of the things, then you have to think of, because for the kidney problem, we nephrologists are so much smart that we do not allow any patients to die of because of the uremia. We prolong giving the dialysis. We have all that. Those who cannot tolerate hemodialysis can go for peritoneal dialysis. Those who do not want peritoneal dialysis can go for hemodialysis. Ultimately, when you can change the organs also, kidney transplantation is a relatively easier job than liver transplantation and less costlier. So that kind of the things you have to balance between what is the life expectancy of the patient and which disease is more severe, which is likely to result into the death of the patient. So that is the clinician's job. That is the job who are taking care of the patient, paramedics who are taking care of these patients. So
Narayan, because others took more time, you will have to sacrifice, and we will have to.
Okay. I think
close the
thank you.
Because you are the secretary, because you are a close friend. So ultimately, मुझे किसी से request करना पड़ेगा. So Narayan will have to.
Thank you, Umesh. We will close the session now. I think we have had an excellent session. Thank you very much. Thank you.
Thank you, Dr. Narayan Prasad, sir. Now moving to the last session of this talk of nutrition in special population, that is nutrition in pregnant females with kidney disease. I would like to invite the chairpersons, Dr. Manisha Sahai, Madam. She is the professor and head Department of Nephrology at Osmania Medical College and Osmania General Hospital, Hyderabad. Dr. Manjusha Yadla, she is the professor and head of Department of Nephrology at Gandhi Medical College, Telangana. And Kavita Gupta, she is the director, head of Department of Dietetics and Therapeutics Diabetic Education at Sunil's Diabetes Care and Research Center, Nagpur. Over to you, Chairperson.
So, good afternoon, everyone. And thank you, Dr. Umesh, for inviting us to chair this session. And I welcome my co-chairs as well. It's a very important topic. And this problem is becoming very, very common because now we are having more pregnant patients with kidney disease because of the improved care.
Dr. Sai, please unmute yourself.
Oh, sorry. So thank you, Dr. Umesh, for giving us this opportunity. Welcome to the chairpersons as well. This is an important topic because we have around 5% of pregnant females who have kidney disease and need guidance on this aspect. And I welcome the speaker of this session, Namrata Rao, to talk to us about pregnant patients with kidney disease. She is Associate Professor of Nephrology at Ram Manohar Lohia Institute of Medical Sciences, Lucknow. And she was awarded Faculty in Clinical Research for the year 2021. Over to you, Namrata, for your presentation. We are looking forward to it.
Thank you, ma'am. And thanks a lot to the organizers for giving me this opportunity. Is my screen visible?
Please share your screen.
Share your slides, Namrata.
Is it visible now?
Yeah,
yes,
visible. Please go ahead.
I'm going to be talking about pregnant patient with kidney disease. The talk will be in the form of some case winners and some approaches. I'll begin with a very well-known adage, which would say a man is what he eats. And adding on to that, a baby is what her mother eats or does not eat during her pregnancy. Well, the magnitude of the problem, as ma'am has rightly pointed out, is that up to 3 to 4% of women of childbearing age are affected by chronic kidney disease. And with the better management that is available to patients at this time in age, the pregnancy rates in CKD women have also risen over time. The major issues which plague these women are that they have a higher tendency of developing gestational hypertension and preeclampsia, conditions like polyhydramnios, IUGR, small for gestational age babies, as well as many more stillbirths than in the general population. Also, the risk of chronic kidney disease later in life is increased in children born to CKD mothers. This is because of the higher incidence of preterm births in this population. Also, in maternal GFR of less than 40 ml per minute, for a majority of chronic kidney disease cases, the mean GFR fall per month increases from a baseline of, let's say, around 0.2 to 0.3 ml per minute fall to almost up to 1 ml per minute per month fall when the patients get pregnant and in the post-pregnancy, as in postnatal phase. Therefore, it's an important problem to consider. So the goals of nutrition therapy in pregnant CKD include optimizing the fetal growth and development, because finally the result of a pregnancy is producing a healthy child. Also, at the same time, ensuring adequate metabolic control for the mother and ensuring that her GFR does not fall too much, and as well as individual recommendations for certain important vitamin and mineral supplements, such as those of the bone mineral axis, as well as those affecting iron deficiency. So I'd like to begin with my first case scenario, which is that of Miss P, who's a 26-year-old patient, a diagnosed case of IgA nephropathy with chronic kidney disease, who was now presented at 12 weeks gestational age. Her baseline meds include amlodipine, calcium carbonate at about 1 gram, and folic acid. She already is receiving docosahexaenoic acid and icosapentaenoic acids, as well as omega-3 capsules. And her weight at this point in time is 52 kilos at 12 weeks gestational age, whereas her pre-gestational weight was about 50 kg, which means she's gained up to 2 kilos now. Height is 158. Her pre-gestational BMI is 20/21, and BP is 130/82, and there is no pedal edema. Her creatinine is 1.7. Pre-gestational used to be 1.89. So, that kind of a fall is predictable because of some improvement in GFR during the first trimester. The hemoglobin is in the anemic range. Urine shows some bit of proteinuria, and serum albumin is 3.98. She asked you as her treating nephrologist for any changes in her diet plan at this time. So what do we think about the weight gain? Do we think that's okay? Yes, we think that is okay, because when we look at cumulative weight gains, they can range from up to 5 to 18 kgs. It is prescribed that patients who are obese should gain about 5 kgs, and those who are underweight can gain up to 18 kgs in pregnancy. Same holds true for up to CKD stage 1, 2, and also up to 3. And of this all weight gain, only up to 1 to 2 kgs of weight gain occurs in first trimester. So our patient who has gained about 2 kilos of weight in her first trimester is probably doing just okay. Higher weight gains have been recorded in patients who have been placed on medical nutrition therapy. Again, something that is probably not accessible to many women with CKD in our population. Now, what to do with protein restriction? This patient would have hitherto been on a 0.8 grams per kg diet. If she was not receiving keto analogs, so possibly she was receiving a 0.8 grams per kg diet. So what do we do with the protein restriction? We can, as far as the pregnancy guidelines go, and those which are extendable into the CKD 1 and 2, is that one can use 1.1 grams per kg per day protein diets in this population. This is again not very evidence-based. And the evidence to support a 0.8 grams per kg per day diet in such females with some additional pregnancy needs is another approach which is followed. This is borne out by some individual case series as well as case studies. Again, the evidence for this is not very high, but the additional protein needs and probably in the first trimester of pregnancy will just be about 1 to 3 grams of extra, and any more extra which is needed needed for proteinuria. Otherwise, it can still be in the 0.8 grams per kg per day range, with 50% of it being of high biological value. Again, there are groups which have suggested giving plant-based proteins in CKD pregnancies. They have been seen to be associated with better outcomes, such as the vegan vegetarian diets in which animal proteins are completely avoided. Dairies are given about once or twice in a week, and the rest of the days the patient receives mostly a vegan kind of protein diet. This is supposed to reduce the glomerular hyperfiltration and thereby contribute to less glomerulosclerosis in the long run. Also, especially so if it is combined with keto analogs, the fetus is not deprived of essential amino acids, and therefore such a diet is thought to be tenable too. So again, coming on to the role of keto analogs, people have looked into this, but the evidence for this is again not strong. It's again based on majority of these studies have come from Italy, where they have suggested a 0.6 to 0.8 grams per kg per day diet as in moderate protein restriction with keto analogs at almost the same dose as we use in non-pregnant persons. And this has been seen to be associated with a paradoxical decrease in early preterm, very low birth weight, and small for gestational age infants. Note this is for very low birth weight infants and not for the low birth weight infants, which is more or less a pretty common phenomenon with CKD pregnancies. Would there be any changes to the lipid prescriptions already given? Well, it is known that omega-3 fatty acids are related to retinal and neurological development. So consistent with existing guidelines, the intake that the patient is taking seems to be pretty good. But in the later trimesters, we need to watch out for whether this patient would develop any hypertriglyceridemia or hypercholesterolemia, according to which these supplements may need to be stopped. So what do we do to raise hemoglobin in anemic patients with CKD? In especially the early stages, oral iron may be prescribed up to almost 120 milligrams per day. And iron studies may be done more assiduously, especially as the stage of CKD increases. And, prior to thinking of ESAs, especially in lower stages of CKD, probably iron profiles should definitely be done. Folate supplementation of 5 mg per day is definitely sufficient, also in patients who are undergoing dialysis. So any nutritional plans to prevent preeclampsia, because this is the kind of population in which we expect them to be at a very high risk for preeclampsia. So one of the things that can be done is to increase calcium intake, which in women with normal renal function as well as with lower stage of CKD has been seen to be associated with a lower risk of preeclampsia. Up to 1.5 to 2 grams per day has been prescribed, but again, in most stages of CKD, we do not plan to go beyond 1.5 grams per day. So at least that can be done. Vitamin D supplementation should also be carried on to maintain levels of more than 30 picograms per ml. Okay, so this lady now continues her pregnancy, and at 28 weeks gestational age, her serum creatinine is 1.8. We're pretty satisfied, while BP also remains controlled. But the urine has now started showing about 2+ albuminuria, a few somewhat increase in RBCs as well. Serum albumin has dipped to a certain extent, and the 24-hour urine protein is up to 3.2 grams per day. Upon pregnancy monitoring, the fetus appears to be small for gestational age. Now, our concerned patient, in whom we did put her on a lower protein intake diet, asked whether she should increase her protein at this juncture. Well, the data on low protein diet, as I had already mentioned, is limited to only single centers, and people have used vegan vegetarian diets with alpha keto analogs, which were associated with a reduction in very low birth weight infants. But these studies were again not associated with much better preservation of GFR in pregnancy or in the perinatal period. Also, we must remember that the amount of proteinuria that is there, that also needs to be replaced from the maternal point of view, along with the pregnancy needs at this point in time. So now moving on to a second case. Now that we've covered some cases of a case of CKD at a lower stage, we go on to Miss R, who's a G2P1 at 25 years of age. She had a stillbirth 2 years back when she was diagnosed with advanced chronic kidney disease, is now on maintenance hemodialysis for the last 20 months, with her basic disease being unknown and almost nil residual renal function, brachiocephalic AVF access, and she has presented with amenorrhea. Again, she has 12 weeks gestational age with single live fetus. She's on multiple medications, as we can see here, and her weight is 50 kilos, and her pre-gestational weight was just about a kilo less than that. And her BMI also does not seem to be in the underweight category, and her blood pressures are moderately raised. There's no pedal edema, and the hemoglobin is 10.4. Among other things, she now wishes to ask you regarding her diet plan. In this particular thing, the weight gain at the end of first trimester, again, we would say that in hemodialysis patients also, there is only up to a kg of weight gain in the first trimester. In the later trimesters, we expect, or and at least according to the existing studies, up to 0.5 kg per week has been seen, especially those with receiving a good medical nutritional therapy. So the weight gain of 1 kg is thought to be acceptable. And the dry weight targets need to be titrated, because it might be possible that even before such a patient who is normally amenorrheic realizes that she is amenorrheic because of pregnancy, somebody may be trying to assiduously try to get her weight down to her dry weight. It may happen not at the extent of the nephrologist, but at the where the dialysis technician himself is concerned that her weight has increased, probably she is gaining more fluid. This is where we need to be very careful about dry weight titration in patients in first trimester of pregnancy and on dialysis. But any changes to the energy and protein recommendations? HD patients in any case would be having a higher resting energy expenditure, so they receive about 35 kilocalories per kg, and some additional pregnancy needs are also covered in this, in which 100 kilocalories are for the first trimester, and these increase up to 300, then to 500 in the later 2 trimesters. In peritoneal dialysis patients, the calorie requirements are lower at about 25 kilocalories per kg per day. This is primarily because of the dextrose that they receive and the additional pregnancy needs as required. As far as protein requirements are concerned, from 1.1 to 1.3 grams per kg per day using the ideal or current dry weight have been used. And further, as the intensiveness of the HD increases to more than, there are centers which use just more than 20 hours per week to centers which use even more intensive therapies than that. With that, the protein intake has to increase a lot. It may be possible that patients might become hypoalbuminemic during such intensive hemodialysis courses. So when they're unable to consume high protein diets and they're showing consistently low serum albumin levels, it may be necessary to give them intradialytic parenteral nutrition in the form of amino acids to improve, and this has been seen to improve pregnancy outcomes in such patients. What are the acceptable fluid gains in interdialytic period? Again, this is extrapolated from the non-pregnant population, and that in any case, we are trying to tackle the fluid gain by increasing the frequency of dialysis. So keeping the gains up to 4 to 5% of dry weight and to balance necessary fluid intakes as a normal pregnancy should be enough. Now I'm moving on to my last case scenario, which is that of Miss T, who's a 32-year-old kidney transplant recipient. She is 34 months since her transplant. Her basic disease was congenital anomaly of the kidney and urinary tract. She's on tacrolimus, azathioprine, and steroid for the last 9 months, ever since she started considering to get pregnant. With a stable graft function at this point in time, she presents at 24 weeks of gestational age with a weight gain of 11 kgs, and she has also developed gestational diabetes mellitus. Her pre-gestational BMI was 21 kg per meter square. There's no evidence of preeclampsia at this point. Apart from that, her medical history in the post-transplant phase has been significant for persistent hyperparathyroidism and hypophosphatemia, for which the patient had to be put in cinacalcet, which was stopped again at the time when she conceived. And serum calcium levels in this patient remain normal. So there are two specific questions that can come up here as to what would be the dietary plan for gestational diabetes mellitus in this kidney transplant recipient, and what is the dietary plan to tackle the hypophosphatemia. Well, GDM in postrenal transplant is attributed to diabetogenic factors such as the use of CNIs and steroids. In some cases, it has also been linked to a longer longer dialysis vintage prior to having received a transplant. And again, specialized medical nutrition therapies advised for gestational diabetes mellitus to maintain nutritional adequacy and also prevent ketosis and prevent outcomes such as macrosomia and other fetal problems. Up to 30 kilocalories per kg per day recommendations are made, of which 30 to 40% of which should be complex carbohydrates. Up to 35 to 40% should be fat, 20% should be proteins, and at least a minimum of 28 grams of fiber is suggested. I would not delve much deeper into GDM because that's again out of the way for nephrologists. Well, management of hypophosphatemia in pregnancy, it's pretty much unknown because most of what we see is maintaining phosphorus in patients of dialysis who are undergoing, who are pregnant. In them, we just stop phosphate binders and we do not really worry much in terms of what next to do about phosphorus. But what about post-renal transplant patients who are hypophosphatemic, which is a very major segment of at least Indian transplant patients? Very high numbers of them are hypophosphatemic. There are several approaches. People have used high phosphorus diets. People have used giving phosphorus supplements, but these are limited by the development of diarrhea, hypokalemia, and other issues. This is a major problem in these patients. There are in fact case reports which are available which describe the development of hemolysis and other issues in patients who are pregnant with hypophosphatemia. And there are centers which have used cinacalcet, ongoing cinacalcet, because it's while the patient is still pregnant, to avoid a severe hypophosphatemia in this population. Well, as far as recommendations in these patients go for pregnant CKDs, there are practically no recommendations available. Whatever recommendations there are combined from those which are being given for CKD and those which have been given for pregnancy. So there's an urgent need for developing recommendations in this population. But this is just to summarize what I had been presenting in the earlier few slides, that in cases of earlier stages of CKD, up to 25 kilocalories per kg per day of energy should be fine. In stage 5 dialysis, energy intakes should be more, up to 35 kilocalories per kg per day. For PD, it could be up to 25. And pregnancy energy needs to be added to the other prescription of energy that we are giving for these patients, which I have outlined as in first, second, and third trimesters respectively. Suggested weight gain is 5 to 12 kgs as for non-renal failure patients. Protein recommendations, again for CKD 1 and 2, we can go with the usual 0.8 grams per kg per day. And for CKD stage 3 and 4, lower can be tried, especially so if we are planning for keto acid supplementation. And we need to supplement the additional pregnancy needs as have been outlined over here, with very low requirements in the initial trimester and increasing towards the later trimesters. Right, and for hemodialysis, higher protein requirements are necessary, as well as for peritoneal dialysis. In fact, there have been centers which have used almost as much as 1.8 to 2 grams per kg per day in patients who are showing small for gestational weight infants, fetuses, and they have given even intradialytic amino acids for the better growth of the fetus. Lipid recommendations have again been pointed out that the total fat recommendation in pregnancy is less than 30 to 35% of total energy, which is similar to the non-CKD pregnancies. And the others are that the cholesterol intake should be kept less than 200 to 300 milligrams per day. Carbohydrate recommendations are also similar to the patients of non-renal failure patients. And the acceptable carbohydrate intake is up to 45 to 65% of total energy intake, and the fiber intake has to be optimized. And the minimal carbohydrate intake which has been suggested is up to at least 175 grams per day. Fluids, again, individualized in the later stages of CKD, especially those who are in dialysis. At least we can tend to be more liberal with the fluid intake, because they're going to have fluid removal pretty much with all the intensive dialysis that they're getting. And calcium, as I said, we need to keep it below 2 grams, and from 1.5 to 2 should be optimal for such patients. Phosphorus restriction may not be necessary. The phosphorus intake should be at least 550 to 700 milligrams. Again, we need to be careful if the patient is also having concomitant hyperemesis gravidarum. It may be possible that even early stages CKD might develop some degree of hypophosphatemia. We need to be careful about that. And vitamin D supplementations have also been thought to be necessary. Iron, HB needs to be kept more than 11 grams per deciliter. Oral and IV supplements may be necessary, and ESA use may also be necessary, and we need to maintain a TSAT of more than 20 and ferritin more than 100. Folate needs can be higher, especially so in dialysis patients. And sodium up to 3 to 4 grams per day, and even 3 gram potassium diets have been given in pregnant hemodialysis patients who are receiving at least about 24 hours of hemodialysis a week, with good positive perinatal outcomes being reported in this class. This is the end of my presentation. The take-home messages are that pregnant CKD women are at a high risk of pregnancy complications, as well as renal disease progression, and of IUGR and SGA babies. As no specific recommendations exist, we need to really adapt the recommendations that are already available. The roles of the renal nutritionist and the nephrologist lie in optimizing these intakes to promote maternal and fetal health, as well as metabolic control. With these adaptations, very low birth weight deliveries and negative outcomes may largely be avoided. Thank you.
Thank you so much, Dr. Namrata. I think the presentation has been excellent and have dealt with all the areas where we have little complex issues with respect to the pregnancy in CKD. I think you have dealt it excellently well. You have made tough easy. But then in Indian perspective, I think we need to have a multidisciplinary team where we manage the patients of CKD from nutrition perspective, as well as, as you said, the Indian experience is very less. The studies that have come are from Italy, whether one single RCT or a single observational study. I think unless the centers in Indian scenario come together to have a registry, probably we will be able to understand from Indian perspective. Thank you so much. You have done an excellent job. As questions are not allowed, I think I would request a comment from my co-chair, Kavita Gupta, and then we wind up the session. And thank you so much, Dr. Umesh Khanna and team, for giving me this opportunity. Thank you so much.
Thank you.
Srnmcon team for that opportunity, and it was a wonderful, crisp presentation. Taking with the flow of the micronutrient and the macronutrient requirement, what is needed during pregnancy, and one by one. I think that was a wonderful talk, very crisp, and I think you have actually touched upon all the points, from the macronutrients to the micronutrients.
Thank you, ma'am. Thank you, ma'am.
Patients.
So one last comment, Namrata. Excellent.
Yes, ma'am.
Only thing, the residents should know the nutritional values of Indian foodstuffs. So which I find alarming. 1 gram dal, 1 katori dal, they don't know. So that also, apart from whatever you told, that also should be incorporated in the teaching to the residents. Excellent talk. Great job. Thank you.
Thank you. Thank you. Thank you.
Thank you.
Thank you all speakers and chairpersons. Now, since we're already a little late as per schedule, we would move straight to our next session, which is on risk factor for CKD progression. For the next session, I would like to please call upon the chairpersons, Dr. Ashok Kriplani. He's Senior Consultant Nephrologist, Bombay Hospital, Mumbai. Dr. Manish Singla, he's Senior Consultant Transplant Physician, Max Super Specialty Hospital, Mohali. And Sana Sahigra, Renal Dietitian, Dr. Kriplani's Kidney and Blood Pressure Clinic. I please request the chairpersons to call upon the speaker, which is Dr. Preeti Meena, who will be speaking on effect of smoking and alcohol on kidney diseases.
Good afternoon, everyone. First of all, thanks to Dr. Umesh Khanna and the Lucknow team for putting us together on this very interesting platform, which I had the pleasure to be on many times, even before, every year. It's a beautiful job being done. My co-chairs you have already been introduced to, but it's a pleasure to introduce Dr. Preeti Meena, who is Assistant Professor of Nephrology at the All India Institute of Medical Sciences, Bhubaneswar. And she will be talking to us about the effects of smoking and alcohol. I think there should also be tobacco in that, because not all tobacco is smoked, but chewing tobacco. So without much ado, I request Dr. Preeti to go ahead.
Can I share my screen now? Please allow me.
Yes,
Please
ma'am.
share, ma'am.
Dr. Preeti, please.
So good evening, everyone. I'll be talking about effects of smoking and alcohol on kidney diseases. So first of all, thanks to the organizer for giving me this platform to express my views. I'll be presenting my topic in the following points. First of all, effect of smoking in the general population, followed by its adverse renal effects in the patients with primary hypertension, renal disease, and then in the primary renal disease, proteinuria, and incident CKD. After that, something briefly about effects of cigarette smoking in the kidney donors and recipient, then briefly about alcohol and kidney diseases. So before we go further about effects of smoking on renal disease, I would just like to highlight the point of impact of smoking in the general population. Worldwide, nearly 6 million deaths are attributed by smoking, and it is expected to rise to 8 million deaths annually by 2030. On an average, a smoker died 10 years earlier than a non-smokers. We all know that smoking is associated with various diseases like cardiovascular disease, COPD, hypertension, cancer, and smokers have high risk of coronary artery disease and stroke that is up to 2 to 5 times. Sorry, I think I can't change the screen. So coming on to the renal effect of smoking in the general population. Even in the patients who are non-hypertensive and non-diabetic, it has been seen that smoking was independently associated with microalbuminuria, and the relationship is dose dependent. Individuals who smokes more than 20 cigarettes per day seems to have a higher urinary albumin concentration. This is a study from Kidney International done in general population, which showed that these patients had slightly higher adjusted creatinine clearance in the former smokers and current smokers. This difference was predominantly found in men and has a weaker association in women. And here also it was found that it was associated with the number of cigarettes smoked per day. And here also again, it was found that the current and former smokers had higher risk of proteinuria. Here there was a theory that maybe the reason was hyperfiltration, because of which these smokers have slightly higher adjusted creatinine clearance, and maybe with a further course of time, it can lead to more kidney injury. In the patients who are hypertensive and had LVH, again, there were higher prevalence of microalbuminuria and macroalbuminuria than the individuals who had never smoked. In diabetic patients, smoking affects all the stages of kidney disease, like the onset of microalbuminuria, progression of microalbuminuria to overt proteinuria, and accelerated decline of GFR in the patients of diabetic nephropathy. If we talk about primary renal disease, there we have plenty of evidence, but the evidences are more substantial for IG and ADPKD. As we can see here, as the number of packs per year are increasing, the rate of terminal renal failure is increasing. It is significantly associated in IgA nephropathy in ADPKD patients. We all know that heavy smoking might be a risk factor for development and progression of post-immune ANCA-positive extracapillary glomerulonephritis, and in anti-GBM patients, smoking strikingly increases the risk of pulmonary hemorrhage. Maybe the mechanism is smoking induces some endothelial cell damage that predisposes to the formation of antibodies against nuclear cell antigen that are excluded from the endothelial cells. If we analyze the result of the CORAL trials, we can see that the smokers were more likely to have bilateral renal artery stenosis and peripheral vascular diseases. And it was also found that the smokers were more likely to have primary composite endpoints like stroke, cardiovascular outcome, deaths, myocardial infarction, and hospitalization. These patients who were smokers were quite younger than the non-smokers. Now, this is a large study done in Korea, published in Nature. It showed that smoking was clearly associated with higher chances of incident CKD in the adult general population. The risk of CKD was 9% in ex-smokers and 39% in the current smokers. Again, it was showed that it depends on the amount of smoking, duration of smoking, and number of packs per year. We all know that already our kidney patients had higher chances of cardiovascular mortality. With the smoking, the cardiovascular mortality and morbidity further increases. And along with that, they have higher chances of peripheral artery disease and critical limb ischemias. Now, coming on to the histopathology associated with the kidney disease, we have a term known as idiopathic nodular glomerulosclerosis, which is characterized by expanded mesangial matrix, glomerular and tubular basement membrane thickening, and vascular hyalinosis. But here, there should not be a clinical evidence of impaired glucose metabolism. And smoking is one of the risk factors for this. Further, by the studies, it was found that smoking is clearly associated with this nodular glomerulosclerosis. So it is not now idiopathic, it is smoking associated nodular glomerulosclerosis. And I also want to highlight here this, yes, it is a characteristic finding in smokers, but it is not that a common finding. We have other common findings which are found in the vascular pathology. We have hardly less than 100 cases described in the literature so far. Like this, the study published in the kidney disease, it was shown that smokers have twice the risk of myointimal hyperplasia of small arteries and higher risk of arterial hyalinosis and glomerulosclerosis. Because smoking actually have deleterious effect on the kidney, primarily through damaging the small interlobular arteries. I won't bore you much with the pathogenesis, but smoking can lead to so many things in the body, like it can increase oxidative stress. Like diabetes, there are high chances of development of advanced glycosylation products. There is increase in sympathetic activation, hypoxia, and also it acts on the nicotine acetylcholine receptors present in the kidney, which leads to increase in fibrogenesis and angiogenesis molecules such as PDGF-alpha, TGF-beta, IGFR, causing hypertension, finally and eventually leading to expansion of extracellular matrix, decline in GFR, and giving a characteristic finding of nodular glomerulosclerosis. Along with that, cigarette smokers are also exposed to significant amount of cadmium and lead, which is found to have accumulated in the kidney tissue more than any other organ. It has a toxic effect of tubules. It has also been seen that individuals who are smoking more than 20 cigarettes per day for longer periods have 45 to 70% higher chances of accumulation of cadmium in renal cortex. Again, this is a series, this is actually a case series published in AGKD with the patient who were non-hypertensive and non-diabetic. It was found to have that because of the smoking, there were changes mimicking chronic hypertension and chronic or heel TMA-like features. Other than that, they have some FSGS kind of picture with ischemic glomuli and some kind of IFTA. So coming on to the implications of smoking in kidney disease, in kidney donors, we have now plenty of evidence suggesting that smoking has deleterious effect on recipient and donors both. For example, the study by Dr. Sage, it was shown that there were higher death rate in the kidney donors who were smokers. They were found to have more perioperative and post-operative complications. There was even reduced recipient survival if the donor was a smoker. Fortunately, it was also seen in some studies that there was a significant drop in cigarette smoking after kidney donation. Like here in the recipients also, there are higher chances of graft failure, death-censored graft loss, less graft survival, and like in general population, higher chances of infections and malignancies. Probably due to atherosclerosis, endothelial dysfunctions, and vascular disease, smoking leads to poor patient and graft survival. Coming on to the effects of alcohol in kidney diseases, before going further, I would just like to tell you that like smoking here also, the effects of acute alcohol intoxication are different, chronic alcohol abuse are different, the effects are different with the amount of alcohol consumed. For example, in this study from NEGM, it was found that there are a wide range of defect in renal tubular function, even in the patients who have normal GFR. For example, there were defects in tubular acidification and impairment in urinary concentration ability. There is decrease in the threshold and maximum absorptive capability for glucose and renal threshold for phosphate excretion. In acute intoxication, there are numerous electrolyte abnormalities. For example, lactic acidosis, hypokalemia, hypomagnesemia, and hypophosphatemia, eventually ultimately leading to acute kidney injuries. But we also have studies which showed that compared to non-drinkers, slightly higher alcohol intake had lesser reduction in GFR over 12 years. Here, there is another study which was published in JAMA. It was the large cohort of apparently healthy men showed that alcohol consumption was not associated with any increased risk of renal dysfunction. Rather, the data suggested an increased inverse relationship with moderate alcohol consumption and the risk of renal dysfunction. So we have some contradictory studies also here. Like in this study, it was found that heavy smokers and moderate drinkers on an average consumption of 30 grams of ethanol per day were associated with a slightly increased risk of developing albuminuria over 5 years of follow-up. So we have mechanism for both deleterious effect of alcohol and some positive effects of alcohol. For example, chronic ethanol injection leads to increased myeloperoxidase expressing cell, leading to induction of inflammatory cell infiltrates, finally leading to other activation of other enzymes like caspase 3, which are increased after ethanol injection, finally leading to reduced GFR, increase in the creatinine and BUN. But the compounds present in alcohol like polyphenols also act as reactive oxygen species preventers and metal chelators. It increases the activity of antioxidant enzymes. So there's less lipid peroxidation, less protein oxidation, and less deacetylation and inactivation of P53. And by this, I would like to say that, yes, the relationship between alcohol consumption and CKD needs a little research, as the studies, epidemiological evidence are largely contradictory. And although we have seen some favorable effect of alcohol consumption on kidney function, but we should not encourage or justify alcohol consumption as it is associated with lots and lots of social issues. Thank you.
Thank you, Dr. Preeti. That was a very comprehensive summary of the the good and bad effects of alcohol and the bad, of course, the bad and bad effects of drinking. Would my co-chairpersons, Dr. Manish and Sana, like to make some comments before I put it open to the audience and make some comments myself? Dr. Manish, any comments, please?
Yeah, yes, sir. So Dr. Preeti happens to have done MD from my alma mater, Maulana Medical College. Feeling proud about that. Usually we know if I deal with kidney patients, as that is usually pertain to something to do with the lungs, and similarly alcohol, which usually is pertain to something to do with the liver.
Yes, sir.
But yes, it is very important to identify these risk factors. And amazingly, we will get to know that once we take the history directed to these two risk factors, we'll get to know that many patients whom we were not suspecting turn out to be having history of either ongoing smoking or alcohol intake. So we need to be more careful about considering these risk factors so that we can aptly control the CKD progression by minimizing these things as well.
Dr. Sana, you and I, we work together. What is your experience with people who drink and justify their drink?
What happens is this was a very good session, Dr. Preeti. It was very informative. But what happens is when we have patients, like I'm, as a dietitian, they're very comfortable with me when they come to me. And there is a bargaining session which goes on. I cannot say no to alcohol or no to smoking. So I'm so happy. I have actually taken a few screenshots of your presentation, and I will technically explain it to them. At the same time, sometimes with alcohol, we have to allow social drinking. But like you mentioned, moderate drinking and heavy drinking makes a difference. So that was also very informative. But as a dietitian, sometimes you have to gradually explain it to the patient. The counseling is very important, and your session has helped me today to make my counseling more better. Thank you.
Before I close, I would like to make two comments. One is that many of these data which show that alcohol is good are funded by the grape farmers and wine growers of America and Europe. With all due respect, I have seen that every time people drink alcohol, their blood pressure goes up. That's the first thing. Alcohol increases blood pressure. Secondly, alcohol reduces the ability to say no to the second drink. Arey yaar, one for the road, come on, le lo, that's another thing. And then it also reduces the ability to say no to the next round of chicken tikka or kebabs. And people who habitually drink alcohol cannot control their diet and their weight and their salt intake, because the first drink reduces your inhibition. Aaj chalta hai, aaj theek hai, Saturday, that's all right. So my personal thinking is that every dietitian should just put their foot down, just like they put down to salt, and say no to alcohol. Then if he wants to drink, it is his funeral, not yours. Thank you, ladies and gentlemen. Preeti, that was wonderful. We enjoyed it, and do keep up the good work.
Thank you,
sir. Thank you, Umesh. And
thank you, sir. Thank you so much. Yeah, I think we can move on to the next session.
Thank you, chairpersons. Thank you, Dr. Preeti. That was an excellent talk. Moving on to the next topic, which is normal weight obesity. It's a very curious topic, and I'm sure everyone is very enthusiastic to learn about it. I call upon the chairpersons, Dr. Archana Baduria, Managing Director, Lotus Super Speciality Hospital, Kanpur, Dr. Rakesh Kumar Sahai, Professor and Head, Department of Endocrinology, Osmania Medical College and Hospital, and Shilpa Shirore Khandelwal, Registered Dietitian and Consulting Nutritionist. I request the chairpersons to please introduce the next speaker and take the session on.
Thank you. Good afternoon to all. It's my great pleasure to be here. I thank the organizers for inviting me to be here. It's my great pleasure to introduce Dr. Mangesh Tivaskar, who's the Secretary General of the Association of Physicians of India. He's a consultant physician and diabetologist at Karuna Hospitals in Borivali West, Mumbai, and he's also runs the Shilpa Medical Research Center at Mumbai. So he's going to speak about normal weight obesity. We have yeah, I would request him to take over and
a message. Unable to connect.
I am Dr. Mangesh Tivaskar, and I would be talking to you
on normal weight obesity. Before I do that, I would like to express my gratitudes, my thanks to entire Srnmcon team, especially Dr. Umesh Khanna and Dr. Akash Shinghada, and all those who were involved in this beautiful conference. I would like to especially appreciate Dr. Umesh Khanna for giving me this special topic to talk. So a big fat thank you to you, sir. Now, friends, we all know that we are witnessing an epidemiological transmission. Transmission from the infectious disease to the chronic degenerative man-made diseases as a primary cause of mortality. And as you can see on the slide, that there is a dramatic shift in the death rate from younger to older, but then from communicable to non-communicable diseases. So we may be living a little longer than what we used to be before, but then very unhealthily. And as far as the obesity incidence is concerned, you can clearly see that India has got nearly 13% of obesity, where they have used body mass index to be greater than 30. And this is a study which was done by Dr. R.M. Anjana for the ICMR. And they found out that in ICMR INDIAB study, the incidence of generalized abdominal and combined obesity in India was nearly in a range of 56 to 70%. But then my question is always that all obese people are sick, or all normal weights are normal? The clear answer is absolutely no. Why? Because the assessment metrics that we use to assess obesity, like BMI, body weight, or waist circumference, or body fat percentage, are absolutely non-standardized, and they do have some gray areas. Like BMI has got limitations that it does not take the percentage of the body fat. Also, it does not consider the organ fat deposition or the variations with gender, age, ethnicity, everything. Neither it considers the metabolic, the environmental, or the genetic parameters. And unfortunately, it was never created to be a measurement of health status. And if you really look at the J-shaped relationship, it also has got a problem, because if you can see here that if you pass in a horizontal line, you can clearly see that the mortality is almost similar at the BMI of 18 to 30, which is not really a very well, I would say, studied parameter. Now, the waist hip ratio is not always reproducible, and especially it is not a useful tool when the BMI is above 35. Coming to body fat percentages, it is not well validated. Along with that, it is very expensive, and not all methods which are usually used to estimate the body fat are practical or sometimes even accurate. So my suggestion is to consider obesity assessment. There are different factors we need to consider when you assess the obesity, right from age, ethnicity, gender, to associated cardiovascular risk factors. And of course, we need to consider genetics as well, and then the other possibly comorbid conditions like insulin resistance or fitness marker or waist circumference, everything. So if you really want to classify obesity, it can be classified into 4 phenotypes overall. Normal weight centrally obese, normal weight metabolically obese, metabolically healthy obese, and metabolically unhealthy obese. We are going to be talking about normal weight metabolically obese. Now, this is the classic Indian phenotype, as we know, or the terminology of thin fat Indian or toffee Indian, thin from outside, fat from inside, or Mound Indian, that is metabolically obese normal weight Indian. Those are characterized by very high insulin resistance, high inflammatory markers, low levels of adiponectin, a classical Indian dyslipidemia triad, and of course, the very high susceptibility to develop the cardiovascular diseases. And the classic example is this YY paradox, where you can see Professor Dr. Chittaranjan Yagnik on your right and Professor John Yudkin at your left. Dr. Yagnik from Pune, PJMC Pune, and Dr. Yudkin from Oxford. And then when they did their DEXA scan, look at the fat percentages at the same BMI. Both had an identical BMI, but the DEXA scan revealed BMI of 9% with Dr. John Yudkin, and in Dr. Yagnik, look at the fat percent. And this paper was an instant international super hit. In fact, this has become one of the I would say, presentation highlight in many of the conferences. So if you really look at the toffee or a MON people, it's not just the fat mass disease, but also it is a sick fat disease, or what we also call as adiposopathy, because it comprises of elevated blood glucose levels. There is an endocrine dysfunction which has happened. The blood pressure goes up, dyslipidemia and other metabolic parameters are there. So if at all we need to actually define obesity in the correct terms, it is the chronic relapsing multifactorial neurobehavioral disease wherein there is an increase in the body fat, but it may not be related to the weight, and adipose tissue dysfunction and the abnormal fat mass physical forces resulting into adverse metabolic, biochemical and psychosocial health consequences. And obesity becomes a disease where there is an excessive body mass, fat mass related to the weight, and it is also influenced by the epigenetic factors or expososome, developmental factors, neuroendocrine dysfunction, medications, nutritional status, unfavorable environmental factors. So remember that the multiple pathogenic adipocytes and the multiple adipose tissue endocrine and immune dysfunction, what we call as sick fat disease, is the situation where you can call the obesity as disease. And this is what I was talking about as a sick fat milieu, where you can see that there is a presence of what we know as a metabolic syndrome. Now we know that adipose tissue is a very active endocrine organ, and it pours out the hormones, the various hormones, which are also called as adipokines. There are over 600 bioactive adipokines which are there, and they have a role in the regulation of appetite, satiety, fat distribution, inflammation, and endothelial function. And they are involved in the crosstalk between the adipose tissue, between the brain, liver, skeletal muscles during the metabolism. And also they act on the macrophages. Remember that adipose tissues are full of macrophages. So any dysregulation happening there induces what we call it as meta-inflammation. And this is usually induced by the nutritional disequilibrium, and there is a presence of dysregulated low-grade dysfunction of the chemokines and cytokines that actually change the immune cell responses. And what happens is that there is an outrageous outpouring of what we know as inflammasomes, which lead to the disruptive crosstalk between the organs of metabolism. And you can clearly see that there is a disruption happening. So adipose tissue in a non-inflammatory state or non-inflamed state or a normal state will have macrophages around 10 to 15% of the immune cells which are present. And the environment is classically called as M2 environment, that is called as an anti-inflammatory environment, where in a non-inflammatory state, there is the high level of cytokine interleukin 10 and interleukin 1 RA. But then whenever there is a hypertrophied adipose tissue or a dysfunctional adipose tissue, the macrocyte and the macrophage population goes higher to 40 to 50%. And this M2 state switches itself to what we call it as M1 stage or a pro-inflammatory stage, causing the secretion of the inflammatory cytokines like TNF-alpha and interleukin 6. So wherever there is an altered immune response, there is high outpouring of macrophages, neutrophils, CD8, that is cytotoxic T cells, the plasma cells, the mast cells, they get active, especially in the visceral adipose tissue. And there is a reduction in the T helper cells and the regulatory T cells and the eosinophils in the adipose tissues. So this is how the lean adipose tissue will look in a balanced energy homeostasis, where you can clearly see that in an anti-inflammatory atmosphere, there are the inhibitory natural killer cells which are high, the eosinophils are high, the regulatory T cells are high, and T helper 2 cells are high. Whereas you can see that here neutrophils are low, CD8 counts are low in a pro-inflammatory phase, and the T helper 1 cells are low. But the moment there is an adipose tissue dysfunction or inflammation occurring or a pro-inflammatory state, you can clearly see that all these regulators like inhibitory natural killer cells, eosinophils, regulatory T cells, Th2 cells, they will all go down and the counter cells will increase. And that leads to what we call it as a very, very angry fat disease, where there is an outrageous outpouring of all these inflammasomes or the cytokines and chemokines outside. See, look at this, where the leptin levels, they go up, the aromatase level, they go up, the interleukin 6, TNF-alpha, and the MCP1, the levels, they go up, and the adiponectin levels, which are protective, will go down. And that leads to the impact on the various organs, and the extravaganza of meta-inflammation continue in liver, causing high insulin resistance, increased glycogenolysis. In the skeletal muscles, it will lead to altered phosphorylation of the receptors, and therefore there is a poor availability of the glucose transferase 4, which is responsible for the glucose metabolism. Then there will be a beta cell strain because of the effect on the islet cell gangrene and lipotoxicity which is happening. And there will be an alpha cell hyperplasia causing the rise in the glucagon levels and reduction in the GLP-1 synthesis. And at brain, there will be a neuroappetite dysregulation, and there is a dysregulation of satiety and hunger axis. And meta-inflammation is usually caused by high amount of mitochondrial reactive oxygen species and leading to endoplasmic reticular stress. And remember that there is a non-enzymatic glycosylation of the proteins causing the increase in the ER stress. And there is a glucose auto-oxidation happening. There is increased free fatty acid release, and a glucose oxidation also leads to increase in the beta oxidation, causing the reduction in the adiponectin. And the vicious cycle continues, that wherever there is an endoplasmic reticular stress, there will be the release of inflammatory chemokines like Januas K and the NFK kappa beta that will stimulate the macrophage infiltration in the adipose tissue, and then that calls for the increase in the cytokine levels. The inflammatory cytokines levels will go up, which will worsen the insulin resistance. Now, these inflammatory cytokines will also increase the meta-inflammation and will also cause rise in the leptin levels and will cause reduction in the adiponectin level. And this will in turn increase the adiposity, will increase the oxidative stress, and will further worsen the ER stress. So the vicious cycle between the inflammation, immune response, and metabolic upset continues, and the interplay goes on. I would just quickly touch upon the the subcutaneous adipose tissue and the visceral adipose tissue. A lot of people, they blame visceral adipose tissue more, and they feel that the subcutaneous adipose tissue can be protected. No, it's not that way. Remember that both the types of adipose tissues, subcutaneous as well as, or the peripheral as well as the visceral adipose tissues, they work for providing the storage of energy, physical padding, and thermal insulation. But more importantly, you need to understand that if adipocyte proliferation and differentiation were sufficient just to mitigate or stop the adiposopathic adipocyte hypertrophy, that means that there is a worsening of the endocrinopathy and inflammation and lipotoxic energy overflow to the other depots. So suppose the subcutaneous fat is able to shift the whole thing to visceral fat, probably the obesity will never occur, or the metabolic disease will never occur. And that is the reason why you need to remember that both SAT as well as VAT are potentially protective as well as pathogenic. SAT and VAT, they do serve as a mass, and the functions are interdependent. So there is also a crosstalk which is happening between a SAT and a VAT, and they both express the endocrinopathies and the immunopathies related to the metabolic disease. And especially in the normal weight, metabolically obese individuals, there is increase in both visceral adipose tissue as well as the subcutaneous adipose tissue. So how do you differentiate between a metabolically healthy obese and an unhealthy obese? There are 4 conventional measures. Measure the blood pressure, look at the HDL cholesterol, find out the triglycerides, and also find out the fasting glucose level. And also some people have few other criteria added. But remember that to say somebody as metabolically unhealthy, at least presence of 2 or more risk factors are necessary, like blood pressure should be higher than 130 or 85, triglyceride levels to be above 150. The HDL levels are usually less than 40 in males and less than 50 in females. And of course, the fasting blood glucose is usually above 100, and the waist circumference is usually above 102 in males and more than 88 in females. If they are not there, then they are metabolically normal obese. And that is the reason why a clear risk stratification can be also done by the estimation of CRP, adiponectin, and probably the presence of fatty liver or NFLD. And this is the difference. Look at the metabolically healthy obese. Even though they are obese, the BMI is 30, but they have got high insulin sensitivity, favorable lipid profile, and lack of hypertension. Whenever there is a metabolically obese normal weight, you can clearly see that there is a high waist circumference, HbA1c goes up, the triglycerides goes up, the CRP levels goes up, the lipid accumulating products, they go up, there is a low HDL, there is a low adiponectin. And almost same is seen even in the normal weight individuals, those who are metabolically deranged. And these are the people, those who are called classically as toffee individuals. And genetics plays an important role in this. Remember that metabolically unhealthy obese individuals, they seem to have a difference in the distribution of the adiposity in comparison to metabolically healthy obese. And specific gene differences, they do exist. And the differences in the gene regulation, especially in the white adipose tissue, is a primary culprit. And both the difference between the amino acids and the branch chain amino acid catabolism, especially happening into the saturated situations in the subcutaneous tissue, will also cause a problem. A very interesting finding quickly I'll share, that whenever there is a weight gain in a normal body weight metabolically upset or the metabolically unhealthy individual, the risk of developing a cardiovascular or the metabolic risk is much higher than the other other persons. So friends, chronic meta-inflammation is a situation which can impact not only the current living, but also can impact the genetic and the phenotypic environments. So all these exposomes, like the psychological stress, then the family history, medication, inflammation, unhealthy diet, the pregnancy and diabetes, smoking, all these things, disturbed sleep, will actually add on to get engraved in your genes, and sometimes your future generations can suffer. So finally, management of toffee, the best way is to have a good therapeutic lifestyle change. Along with that, you are looking for tobacco cessation and target specific pharmacotherapy. I will not go into the details about this because of the want of time, but remember that the basic mantra to treat this toffee or metabolically obese normal weight people is prevention. And these prevention policies have to be more proactive than reactive. So to summarize, you need to understand the differences between the metabolically obese and unhealthy individuals, metabolically obese but metabolically normal but overweight individuals. You need to also understand that the outcomes are much worse in normal weight metabolically obese individuals in comparison to metabolically healthy obese people. So understand the differences and act accordingly, and the best way to treat is prevention. I'll end up with the saying that 1/4 of what you eat keeps you alive. The other 3/4 keeps your doctor alive. This was the heliographic writing found in the ancient Egyptian Rome. Thank you very much for your kind attention.
I think hello.
Yes,
I think
yes.
the chairpersons could give their remarks,
Yes,
because Dr. Tivaskar has sent a recorded version. So
okay.
Yeah.
Indeed, it was. This is Shilpa Shirole here. Indeed,
Yeah.
It was a very thorough topic which he had presented today. And yes, what he talked about the traditional assessment matrix. Apart from that, how we need to look at the metabolically unhealthy individual. That was something which we really need to look forward to, and how an anti-inflammatory body can also turn into a pro-inflammatory body, and you don't even realize because it's not seen in the anthropometric or so. So these are very insightful points which Sir did highlight, and I think the next chairperson would also like to add on his comment.
Dr. R.K. Sahai. Is Dr. Sahai there? Archana? I think, is there a sound problem, Archana?
Sorry. Okay.
Yeah, now it's fine.
Okay. And thank you, Dr. Umesh, for giving me an opportunity to chair this session. In our clinic, we see so many times thin individuals who have thin arms and legs, but are pot-bellied. I think they will fall under this category of skinny fats, and it will be a lifestyle modification, counseling, which would be required for them to prevent them to be at risk for cardiovascular events and diabetes. A very good presentation. Thank you, Dr. Magnesh.
Is Dr. Sahai there? I'm not able to see him.
Hello, yeah, Dr. Umesh, there is a problem with Rakesh's this thing.
Okay, so he can join anytime he wants because we want him to the next in the next presentation also.
Yeah, I'll tell him. I think he's trying to connect. We are at separate places. He's in the hospital. Probably there is some internet connection or something there. So I'll tell him. I'll tell him.
Yeah, at this age, you tell him Dr. Khanna feels that both of you all should be at the same place. Anyway, thanks so much.
Thank you. Thank you.
Thank you.
Excellent session, Dr. Mangesh. Excellent.
Yeah, I would need Dr. R.K. Sai in case he comes because we are facing a
Sure.
problem. And as COVID has taught us, when you face a problem, you try and modify things. So Dr. Shashank Joshi is stuck in Jaipur with heavy rains and lack of connectivity is the message that he has given. So I would request the chairpersons to be around and, we can have just a discussion on certain aspects of keto diet, intermittent fasting, and the era of SGLT2 inhibitors. So the chairpersons from this presentation, if any of them wants to be also a part, can be there. And let the anchor introduce Dr. Sandeep Mahajan, Hemant Mehta, and Niti Desai.
Yeah, thank you.
No, I think we are at the keto diet session, right?
Yes, sir. One slide back.
Yeah, one slide.
So,
yes.
One more slide. Yeah. So sadly, we'll not be able to have Dr. Shashank Joshi with us right now, but we'll still have a discussion on keto diet, intermittent fasting in the era of SGLT2 inhibitors. Like Sir mentioned, if COVID has taught us anything, one thing it has taught everyone is to pay attention to their nutrition, especially because we couldn't step out. And keto diet and intermittent fasting is maybe a diet fad, is maybe something which is very relevant, but everyone seems to be
it's basically we were running late, so we'll to 10 minutes and we'll try and have chairperson's remarks on this topic you can introduce them and then each one can give remarks on their version of how keto diet or intermittent fasting should be handled in the era of SGLT2. You can introduce the chair.
So for this, I'll introduce the chairpersons. Dr. Sandeep Mahajan, he's Professor Nephrology, All India Institute of Medical Sciences, New Delhi. Dr. Hemant Mehta, Interventional Nephrologist, Lilavati Hospital and Research Center, Mumbai. And Niti Desai, she's a consultant nutritionist, secretary and master trainer, Association of Diabetes Educators. So I request the chairpersons to please comment and share their views on keto diet and intermittent fasting in the era of SGLT2.
So I have to apologize, the chairpersons, that I've got the message just now, 5 minutes back from Dr. Shashank Joshi. And I thought this is, let me take advantage of the fact that all three stalwarts are here who are well versed with this topic. So let's hear from them, their version of it. We have about 10, 12 minutes, 15 minutes, we can discuss it at least. Any of y'all can take Hemant Mehta, Sandeep Mahajan, Niti Desai. Some comments from each one of them.
Okay, if I can start first, sir.
Yes, of course, Sandeep.
So
AIMS has done a lot of work, yeah.
So SGLT2 inhibitors, obviously, the most outstanding drugs or most outstanding molecules which have occurred to us as far as cardiovascular risk profile reduction is concerned and renal profile reduction is concerned in say past 3 or 4 years. We all have been using it for past 4 years now. Good drugs. We have sufficient data on their short-term and long-term safety, especially even in real-world setting. We talk about so many trials in which they have been found to be useful. Obviously, what happens in trials is not what is replicated in real world. But for past 2 years, we have significant data coming even from Scandinavian cohort, American cohort, suggesting that they are long-term safety even in a real-world profile.
So Sandeep, the real world which we wanted you to tackle is in the real world. Many of them have these, fad diets and things like that. So if they are on SGLT2 and they go for intermittent fasting or they go for this, keto diets, are they at higher risk or something like that? So this was the point I wanted you to make.
Yeah, that's what I was coming to. The only problem or the only point which we have to emphasize when we are prescribing them SGLT2 inhibitors is give them sick day rules or give them when not to take SGLT2 inhibitors. My usual sick day rules are if you have fever, you have diarrhea, you're feeling low, dehydrated, you are fasting. So these are the times when you should be avoiding SGLT2 inhibitors. They are known to produce ketosis, especially the most dreaded form, obviously being supposedly normal glycemic or very low. The blood sugar levels are not that high and you have ketosis. So this is one thing which I usually include in my sick day rules counseling when I tell the patients that if you are fasting, definitely don't take SGLT2 inhibitors. One, they are difficult to diagnose. Number two, obviously your chances of having this rare complication increases. In credence, the chances were more than 10 times. But if you start fasting, then obviously the chances would increase manifold.
So before Hemant has the last word, Niti Desai will tell us how many of your patients indulge in these kind of fads, and do you see these days a much more trend of going into these kinds of diet for weight reduction, and how good they are, and whether you warn them about some of the aspects of intermittent fasting or keto diets? Niti, your comments. You are mute. You will have to unmute. Niti.
Yes, I'm there.
Yes, yes.
Thank you, Dr. Khanna and Samrudh Patel for having me here. So intermittent fasting and keto diets, as Dr. Khanna said, are the flavor of the season. We have a lot of patients who follow this. Now, when it comes to use of SGLT2 inhibitors and keto diets, I think that's a kind of a red signal. We generally will discourage them from going on a keto diet if they are on these SGLT2 inhibitors, because it's kind of a combination of ketosis. There is a nutritional ketosis because of the ketogenic diet, which is not so harmful, but combined with that ketosis because of the use of these inhibitors. And this situation can spiral out of control. Also, I think studies have shown that to resolve this euglycemic ketosis takes double the time than you would take time to resolve the normal ketosis that we see in diabetics. So when it comes to keto diets, we would actively discourage them from following it if they are diabetic and using these inhibitors. When it comes to intermittent fasting, it is not such a bad deal because there is a sufficient caloric intake going. It's just that the time period is limited. So either the modification of the dosage will have to be done. It also depends on what kind of IF people are following. So if somebody is doing 5:2 or is completely fasting on a day, then we would ask them not to take that inhibitor on that day. If there is a risk of dehydration, if there are those severe fasts which being followed, then we would ask them not to use. But regular intermittent fasting 16:8 or where they are eating for 16 hours, not eating for 8 hours, not eating for 16 hours, you can still use the inhibitors with caution.
Hemant, how frequently are you seeing this euglycemic ketosis? And obviously in those where there are specific reasons like infection, etc., it's known, or surgery or fever, but do you see this kind of situation, or whatever your comments on intermittent fasting and keto diet, or in general about keto diet? Is Dr. R.K. Sahai there? Manisha?
He's out of contact, sir. I think
okay, fine.
He was there in the beginning of the session.
All right.
Used and all, I'm not able to get him.
Okay, we wanted his comments on normal weight obesity also.
Yeah, probably some this connection problem or
Fair
something.
enough. Fair enough. I think we are facing that. Hemant, you will have the last word.
Okay. Thank you, Umesh, for having me here. Me and Umesh have been close friends from KM days. I think we know each other now for last 40 years.
Yes.
And he's very smart because he has combined 3 topics into one. He has put keto diet, separate topic, intermittent fasting, separate topic, and SGLT2 inhibitors. 3 topics into one.
And he has given 3 minutes to talk.
3 minutes to talk. I mean, then also he will say after 2.5 minutes, hurry up, we are running short of time. Okay. So having said that, I was, of course, looking forward to listening to Dr. Shashank Joshi, who also happens to be from KEM. and now we work together at Lilavati Hospital. So having said that, just last week we had Indian Society of Nephrology based on chapter meeting where there was a mini oral presentation where we had submitted a paper on our series of 4 cases of SGLT2 inhibitor related problem. 2 out of these patients were post-operative euglycemic ketoacidosis. So that point has to be highlighted. And there are recommendations which have come from Australian Society, which says very clearly that you have to tell patient to stop SGLT2 inhibitors at least for 3 days, but ideally for 5 days prior to any intervention, which even includes gastroscopy, colonoscopy, and things like that. The problem is patient don't think this is important to inform to the person who's going to perform whatever intervention. And like say, for example, person going for or operating on CABG or doing a colonoscopy does not know that patient should be asked about this history, especially now in the era where even if they are not diabetic, if they have a cardiac problem, they could be on SGLT2. If they have a renal problem, non-diabetic, they could be still on SGLT2. So this point was highlighted, one. Secondly, yes, if there is any intercurrent illness, whether it is febrile or non-febrile illness, we have to stop SGLT2. And number 3 was SGLT2 leading to pyelonephritis and acute renal failure was the 4th case which we presented. So though they are very good first, second line of treatment, add on to metformin, but it comes with a price and one should be aware about, though rare, but side effects are known. Now, when it comes to keto diet, it can cause ketosis. SGLT2 can also cause ketosis, so that goes without saying. As far as intermittent fasting is concerned, I mean, we know people who are fasting in the Ramadan period. So, they obviously modify their diabetic medicines now. And obviously in such a situation, SGLT2 probably will have to be stopped again for the risk of its complications which can arise. But going for an intermittent fasting as a strategy to control diabetes and weight reduction, I don't think there is very solid, concrete evidence for that. We have known certain communities who fast for say 12 hours a day or once a week or 1 full month and things like that. I don't think they lose their weight so drastically, so to say. And that's why whether we should recommend our patients to go for intermittent fasting or not, that itself becomes a big question mark. And if they happen to be also on SGLT2 inhibitor, then we'll have to tell them to be very cautious and stop the drug in that period of so-called fasting for 16 hours or so.
Right. So I'm missing the endocrinologist, but I think my dietitian friends will try and help me out. Whoever wants to answer what Hemant said, how good is intermittent fasting, or more importantly, keto diet as a weight reduction measure, irrespective of SGLT2, irrespective of kidney disease, pure obesity treatment or diabetes treatment in the form of keto diet or intermittent fasting? And any of the dietitians can take it, including Niti. Anybody wants to take it.
Right. So we do not have enough evidence for keto diets. There is evidence that at the end of 6 months, there may be a slightly significant more decrease in weight when you follow a keto diet, but just go over 1 year. And the data shows that there is no significant difference between conventional calorie restriction and following a keto diet. So the jury is out in that sense. That keto diet over a longer period of time is not sustainable, leads to hyperlipidemia. So as a weight loss tool, maybe not a great idea. It's been always used for epilepsy, yes, but for a weight loss, not a great idea. Intermittent fasting, there are more and more studies which are coming out saying that perhaps it has other benefits besides weight loss, longevity, decreasing the inflammatory state. In fact, even yesterday, I think a couple of studies have come out saying they are cardioprotective. So that we can still continue to debate for the months to come.
Well, thanks everybody. I must apologize and thank the chairperson. Apologies because they had come to chair and listen to Dr. Srnmcon Joshi. Instead, they had to listen 5 minutes of my nonsense. And thanks so much because you all were able to help us in tiding over the loss of a session. And now both A hall and B hall are running neck to neck on time, the way we wanted everything to be on time. So over to Smriti Sinha, and thank you all, the chairperson. Smriti can conduct the rest of it.
Thank you, everyone. So now moving on to our next session, challenges in CKD nutrition. For this session, I'd like to request our chairpersons, Dr. Urmila Anand, Senior Consultant and Head, Department of Nephrology, Yashoda Hospital, Sikandrabad, and Kavita Bakshi, Convener of Indian Dietetic Association, Nagpur Chapter, Women's Technical Education, to kindly please introduce our speaker who will be talking on role of salt in CKD.
Yes, thank you, Smriti. I would like to welcome and introduce Rajan Ravindran sir, who is the Chairman, Sapiens Health Foundation, Director, Nephrology, Miyot Hospitals, Chennai. Over to you, sir.
Well, Ravichandran is extremely passionate about salt, and therefore he's absolutely the right person to give us the perspective of salt and whatever different aspects of life. But here, of course, he has a topic on salt in CKD. Ravi,
how do I get the power presentation?
Sharing rights.
Sharing the slides. Yeah.
Technical team, please help Dr.
Yes, sir.
Ravichandran.
Sir,
Yes.
there is a green button, share screen. Please click on that.
Yes. Yeah, share screen.
And select your PowerPoint and then share.
You have not uploaded, is it? Oh. I
So
thought it has been uploaded.
If the slides are there with the technical team, if you want them to run the, yeah. So
yes, sir.
I think you can run the slide. Yeah.
Yes, yes, sir.
That will be better.
You
I am
can
little,
yeah, you are like me, old timer.
Not very computer savvy, so you should excuse me for that.
Yeah. I think your gray hair actually tells us. Not a
I thank
Mr. Rohit,
the
please
organizers.
share the screen, please.
What do I do?
No, sir. I am asking my technical person to share your slide.
Okay.
Meanwhile, of course, Ravi, you can start your talk.
Yeah, of course.
You can give it in sleep also.
Yeah, it has come.
At a spinal level, you can give it, not a problem.
Yeah, so thanks, Umesh, and I thank the organizers of this conference to give me this opportunity to talk on salt. As Umesh said, even if I'm not given an opportunity, I still talk on salt.
Yeah.
So only thing is, I hope Umesh has sent, I just received the pizza. I hope it is a low salt pizza that has been sent. I'm not sure.
You kind of let the cat out of the bag.
Yeah, yeah, rightly. Yeah, two things. The Sapiens Health Foundation is an organization I run for the last almost 25 years. And for the last 10 years, our main campaign has been reducing salt intake in the population. For various reasons, you can visit our website and get more information about it. The other aspect is I'm also in Miyot Hospitals as the director of nephrology, and a recent study which we did was in the donors in the last 10 years. And we found that the slides to go, how do I move the slide? Excuse me.
Sir, just say next slide, will move your slide.
Okay, then go to the
old
previous
system.
slide.
Yeah.
Go to the previous slide.
Go to the previous one.
Previous. Yeah, okay. So at Miyot Hospitals, I'm the at Miyot Hospitals also, and recently we did a study on all the donors in the last 10 years, and we found that a fair amount of almost 90% of the renal donors were consuming more than the recommended salt intake. And we were a little concerned, and now it's been our policy to recommend, along with post-transplant instructions, the donor to cut down the salt intake also. Salt is nothing but common salt is sodium chloride. Now we all know that it's a preservative. Actually, the word is from the Roman word salary. So salt was such an important substance 7,000 years back. If you don't salt the fish, the food would rot. The bacteria would grow. Even now, if you put salt and sugar, the ant will never go to the salt. It will go to the sugar. Traditionally, we use throat gargles with saline throat gargles. We all know that it has strong anti-bactericidal or germicidal action. So it's a very strong preservative. discovered about 7,000 years back when preservation was poor. But what is surprising is even now, the best preservative known to man is salt. So you will be surprised that any food that has a long shelf life has high salt content. Otherwise, it would not last. For example, you are going to eat a sweet cookie, you think it doesn't contain sodium, but even that contains sodium. So sodium is still being used as a rather the strongest and the best preservative, and you have to be very careful in realizing the hidden salt. So relationship to blood pressure, I think now everybody seems to know that there is some relationship to blood pressure. But if you look at it, the temper, there are umpteen literature in our literature where it says that if you take salt, you are your temper is more. So to that extent that I found there is a reference in Bhagavad Gita for a sattvic food to reduce the salt intake. Similarly, a Muslim friend of mine told me that even in Quran there is a mention about salt and temper. The relationship to BP is being established for years. There is a tribe in the South America which is not exposed to salt at all. Their average blood pressure is only 90/60. Even now, this has been shown only 5 years back. For that matter of fact, apes in the jungle have a blood pressure of 90/60. Once they were put in the zoo and given the human food, the blood pressure goes up to 130/90, which we consider now as a normal cutoff. Why I'm trying to mention that is we get complications of vascular disease even with normal blood pressure. For example, somebody having a normal blood pressure still having a kidney issue or a cardiac issue or a stroke. That is a large number. It's not necessary that you have to have a very high blood pressure. What are the source of salt? Natural. Whatever you do, see, sodium chloride is present in vegetables, fruits, meat, whatever it is. So that's about 1 to 2 grams. The second important one is added while cooking. So this is, of course, mainly in the hands of the homemaker. I don't say housewife because homemaker can be a man also. I see that in the US, often homemakers are men. They are good cooks. So reducing salt while cooking, I'm sure your nutritionist would give you tips how to cut down the salt and improve the taste. So that's an aspect. Preserved food. Preserved food is the hidden salt. As I said, longer the food shelf life, higher the salt content. Pickles will last for 6 months, 1 year. Instant noodle, which is a big culprit. Actually, Maggi used to have a high salt content. After we wrote to several of the companies, about 300 companies all over the country, they have reduced the salt content now in noodles. For that matter of fact, I see now some awareness about salt consumption in the population. Next one. Of course, what are the hazards? As I said, the relationship to hypertension has been established long back. That sodium, I'll explain to you later how it produces it. Strokes and heart attacks, even in the absence of high blood pressure. This is the recent study which came from China. I don't know how many of you had seen. Very, very interesting that when they substituted the salt with the potassium chloride partially, you can substitute up to 25%. When you get these salt substitutes, they found there is a drastic reduction in the strokes. Very interesting. Renal stones. So what salt does is when sodium chloride goes in the urine, it tracks the calcium. So it tends to form salts. So it's very interesting that high salt eaters get more renal stones. So you should ask somebody who gets stones to reduce salt. The next slide, last one. The previous slide, please. Yeah, osteoporosis. Again, as I said, as the calcium gets drawn, the bones become weak. Next one. So what does WHO recommend? The WHO says we have to eat 5 grams of salt from all sources. I have to write this word again and again, all sources. Because if I sell just 5 grams, people think that they can use 5 grams of added salt per day. No, it includes all the salt. It includes salt in the natural food. It includes salt in preserved food. Unfortunately, in India, only now the salt labeling is getting common. Whereas abroad, all foodstuff has to have a salt labeling. And UK is very good that it doesn't allow people to label as sodium. It says, please label as salt. See, 1 gram of sodium corresponds to 2.5 grams of salt. People understand salt. People don't understand sodium. So unfortunately, in some labeling, it mentions only as sodium, which has to be multiplied by 2.5. So what is important is salt. So WHO recommends less than 5 grams. It's very, very difficult to achieve. Children, it has to be less. First year of life, you don't require salt at all. And by the age of 12, you should come to approximately the adult consumption. Next one. See, this is a recent study which came in the Lancet, which was very shocking that such a huge population was studied, and they found that the incidence of hypertension has doubled in the last 20 years. Very sad. It is all gone. It's not by changing the standards. I am not, this is 130 by 90 as cutoff, not the 120/80 cutoff and not that one. The 130/90 cutoff itself, more than half the population it is doubled, and not only that, more than half the population are not even aware that they have blood pressure. When they are detected to have high blood pressure, they don't know that they have blood pressure. And then more than 50% don't receive any form of treatment. This has been very shocking. And this has been studied in 184 countries. India is coming quite backward in the awareness as well as in detection of hypertension. Next one. If you look at elimination of salt, see, basically people have some wrong idea that salt can be removed on sweat. See, normally the salt, almost once you achieve a steady state, is removed only by the kidneys. Almost all the salt that you take. Very small quantity goes in the feces, stool, and sweat. Once you get acclimatized, the salt content is very low. It is less than 5 milliequivalents per liter. Actually, if you taste your skin and you find that it is salty, it means that you are consuming more salt. So to that extent, that how do we judge somebody's salt intake? We do 24 hours urinary sodium excretion. That is the gold standard of salt estimation. Next. Let's see how the kidneys handle the salt. So basically, it's freely filtered, the salt. So 180 liters is being filtered of blood per day. So the reabsorption takes place in the proximal tubule. I'm sure you are aware of the breakdown of the nephron. And the major portion of the sodium is reabsorbed at the proximal tubule, 25% in the thick ascending limb, and 5 to 10% in the distal convoluted tubule, and 2% in the collecting duct. See, the importance is certain diuretics work in different areas. For example, there is a group called thiazide which control blood pressure very well. They work in the 5 to 10% because this is the tuning, fine tuning. Whereas some of them work in the thick ascending limb, like the Lasix, or that is furosemide, I'm sorry. Or if you go, some of them have the proximal tubular. That is very rare. Nowadays, we don't use these diuretics. Next. Next. So there are a number of hormones which the kidney uses to control the salt excretion in the urine. Angiotensin 2, aldosterone, vasopressin, catecholamines. They act in the different parts of the kidney and they all regulate our salt excretion. Next one. So this is an important aspect which I want you to know. Well, why is it that people take salt? Some people get hypertension, some people don't get hypertension. Some people reduce the salt in the diet, the BP falls, in some people it does not fall. So this is based on the salt sensitivity or resistance to hypertension. When salt increases, you will find, I'm sorry, I'm exceeding the time. But when salt increases, the blood volume goes up. That's the reason for the cardiac output going up. Normally, nitrous oxide should be produced more and resistance should fall. So that is what happens normally, and the BP doesn't go up. But in a salt-sensitive person, the nitrous oxide production is low and the resistance goes up paradoxically. So they get, even with small quantity of salt, the BP shoots up. So this is based on genetic and environmental factors and it changes with time. Next. So the Japanese study showed that in 4,000, this is a recent study in 2020, 4,075 patients, stage 1 to 4 CKD, and the urinary salt correlated very well to urinary albumin creatinine ratio and macroalbumin. So if you give, everybody knows, greater the protein loss, faster is the progression of chronic kidney disease. Next one. What is the recommended this thing? The KDIGO is similar to the WHO. So CKD requires, almost every patient of CKD requires a salt restriction. The recommendation would be approximately less than about 5 grams of salt per day. Don't put on complete salt-free diet. You can get into trouble because the volume can drop, the renal function can deteriorate. But some salt restriction is required almost in all patients except those who have salt-losing nephropathy, which is very rare. Salt substitutes, previous slide. Salt substitutes Again, as I said, contain potassium chloride to various purposes. So you have to be careful while using in chronic kidney disease. Salt losing nephropathy is a rare one. Next one. Next slide. Association between urinary salt. See, this is the Japanese study which I told you. The next one. Yeah, there has been 11 randomized control trials which have shown that if you reduce the dietary salt restriction, there is a preservation of kidney function and reduction in protein loss. This has been over several years. 11 RCTs have been done. Next one. So this is the Lancet study, I think, which showed that very high incidence of blood pressure. Next. So summarizing, salt doesn't produce chronic kidney disease, but chronic kidney disease can worsen with high salt intake. There can be a reduction in the GFR as well as protein leak. Both can worsen the progression of chronic kidney disease. Actually, sodium directly damages the vascular endothelium. So it's a myth to think that if your blood pressure goes up because of salt, your kidneys are damaged. Even if the blood pressure doesn't go up, still your kidneys can get damaged. As I said, almost every person with a chronic kidney disease requires a salt reduction. Thank you. I think I'll give a little time for discussion.
Thank you, Dr. Rajan Ravichandran. An excellent presentation, and I am aware of your passion and fascination for salt. And most of us have learned from you, and we also now tell our donors to salt restrict and look at their urine protein creatinine ratio and blood pressure every 3 months. Now I don't see Dr. Umeha, I see Dr. Khanna. Now I go back to the last session. Does your recommendation about salt restriction holds true in this era of SGLT2 inhibitors? Because you said 65% of the salt is absorbed by angiotensin II.
Yes. See, I haven't seen papers which are showing what happens to the urinary sodium over a period of time. So initially, obviously, the urinary sodium goes up, but over a period of time, does it still remain high with the use of SGLT2 receptors? I haven't really seen these papers, but definitely whenever there is a volume depletion, that is the time you don't require a salt. This has happened with the use of these new drugs. Some of them get into a volume depletion and the renal function actually worsens. So
we see this most commonly, sir.
So I don't know how judicious it is to increase the salt for that. Rather, I would try to cut down the medicine rather than try to increase the salt. I'm not sure whether we can balance that. Because as I said, there is an action of the sodium directly on the vascular endothelium also. Even if your BP does not go up, still you can have damage to the vasculature.
Any questions from the audience?
No, you have 5 minutes. You will have to keep on asking questions.
So
you are one chairman who has the luxury of asking questions.
Yes.
I'm sure he will answer back. What do you say about DASH diets? I mean, does it sort of prove your theory or disprove your theory? And what are the second question is, what are the situations where you will tell your patients to be cautious about salt? And the third, I see a lot of dietitians. What about salt substitutes in our kidney patients?
So DASH diet was the first one which showed that reduction with the salt intake is associated with reduction in blood pressure. So as I see, it's very interesting that the reduction is not great, The reduction is only to the extent of 4 to 5 millimeters. But the benefit that it happens, but this is surprise. I'm sure you would not be surprised with all the BP medicines. The studies show only marginal reduction in blood pressure. They never show drastic reduction in blood pressure.
But what is your experience if you ask them to take salt restricted diet and the medicines together? Does that make a difference? Have you ever looked into that? Sir?
So I think what I do is I always put them on salt restriction first. And I don't use diuretics because I feel diuretic side effects are more, especially the use of thiazide and the older diuretics, chlorthalidone, etc. We do have high incidence of hyperglycemia, hyperuricemia, hyponatremia, and hypokalemia, electrolyte disturbances. And very often the physician forgets to ask them to restrict the water intake. So hyponatremia is a big concern in people who are on diuretics. So diuretics, I use it only cautiously. I don't use it for hypertension. I use it only for volume bloated, expanded states where the person has an edema. In the absence of an edema, I would think twice before using a diuretic. So clinical judgment is very important, that somebody who has an edema, obviously we restrict the salt intake more and the water intake to an extent. But if there is no clinical edema, obviously you don't require such tight sodium restriction in these people.
What about salt substitutes, sir?
Salt substitute, as I told you, there are several available in the market. The commonest ones are addition of potassium chloride, like you have this Lona salt, etc. So you can go anywhere between 5 to 25%. Beyond 25%, if you add potassium chloride, the taste changes. So you cannot do that. So they go anywhere between, normally they are all at between 5 to 10%. The other ones that are available are the Himalayan salt or the rock salt. These contain additionally calcium and magnesium chloride in addition to the sodium chloride, but they vary with every batch to batch. So they really don't have a correct scientific one. Whereas the low salt, which is marketed, has Lona salt. Tata is.
So there is another question from.
There are other companies who are also.
Some question, I think there is a misconception that if you restrict salt, you develop hyponatremia. How do you answer to that, sir? Because that we see regularly in our practice.
Yes. Hyponatremia is a ratio between, people have to realize it's a ratio between sodium and water. It is not an absolute value. It doesn't tell you, looking at a low sodium, people have a wrong idea that it tells you what is the body's sodium content, which is wrong. So you can have a low sodium with low body sodium, with normal body sodium, with high body sodium. All three can happen. So I think you have to clinically examine and decide. It's only a ratio. So if you bring down the water content, the sodium will start going up. So the hyponatremia usually is a marker that the person has been taking more water. And this happens especially with the diuretic, because diuretics impair what is called the free water clearance by the kidney. So since this free water clearance is affected in both CKD as well as due to diuretics, you have to mention to people who take diuretics to restrict their water also to an extent.
True.
Yeah.
True. Kavita, any questions? Or there is another question. Is
there is one more question there, ma'am.
Kavita, you can ask. You can ask.
Yes, is it possible to achieve 5 grams of salt in Indian scenario?
So Ravichandran himself is on 5 grams, but we must look at other people.
Actually,
many of us, I'm also in 5 grams, sir. No salt
I eat much less than 5 grams. I eat even less very often. Unless I go out, I don't eat salt. As a thing, actually, I should say my blood pressures are pretty low. So, and I'm very comfortable. So I'm sure that a lot of people you can achieve. If you avoid adding salt, that's one of our campaigns is to get rid of the salt shaker from the restaurants.
Yes, table salt.
So you keep a salt shaker, people don't even taste. They just add salt to the soup and then they eat it, They don't even look whether there is a salt. And if you're going to eat fresh food, if you go to restaurants, especially if you're going to eat North Indian type of food, there is no problem at all. You can tell the chef to add less salt and they prepare it. We get facade only in South Indian food where idli dosa is already added. So we can't change it. But you can even, when you eat outside, you can reduce your salt. I think it's a temptation. And not only that, people think that taste is bad if you don't add salt. This concept has to go. That if you reduce salt, actually you start appreciating other tastes. You know what is sourness, what is bitterness. See, salt and sugar are dominant tastes. You can't appreciate other spices. If my cooking is poor, I add more salt so that I camouflage everything else. If you add less salt, you'll start enjoying the herbal flavors. You would see if you go to a menu abroad, you'll find on the recipe it gives 10 ingredients. And the chef will bring out the flavor of each ingredient by adding less salt. A French chef, I believe, will get into shock if you tell him to add salt in his food.
Yeah,
so they get so perturbed because salt will kill all taste.
Yeah, actually we tend to use mango powder or lemon to enhance the taste if we give low salt.
I'm sure it is an awareness that if you put in efforts, people would. And see, the other point is your taste buds are saturated. It's like alcohol or other smoking. You require more and more salt to satisfy yourself. You don't eat salt for 2 weeks, your taste buds recover. Then you go and eat somewhere, you will say, this is very salty. True. I cannot eat this. So you start appreciating, your taste buds recover. So I think it's a matter of practice and what we should put in efforts. And I request the dietitians, they are the primary people who can guide the patients.
Thank you, sir. Thank you, Dr. Ravichandran, for this excellent presentation. I think
Welcome,
Akash will move on to the next session.
Yeah, Dr. Smith is there. Smith is. Akash has come. Okay.
Thank you, sir. That was genuinely an excellent presentation, very enlightening. Now, moving on to our next
Dr.
topic.
Akash has some
Yes,
questions.
Yeah. So, sir, I would invite you to chair this session. Dr. Anand Joshi is unable to join. If you can chair the session in place of Dr. Anand Joshi, sir. Dr. Khanna.
Ravichandran is standing.
Can you hear me?
Yeah, I think Rajan Ravichandran is willing.
Sorry. Okay, fine. Perfect.
Dr. Ravichandran, if you have a VIP like him, we can always ask him.
What is it?
You are chairperson for the next session also, because it was
the next session. I have to, how long will it take? Short time?
Yeah, I think because anybody who gives an excellent talk is made to sit for the next one also.
Good
you are a dangerous fellow. I know that.
It's okay. It's okay. If you can, fine. Otherwise, we are there.
Yeah, I think I will leave because
Sure,
I'll
no
go
problem.
for my, Thank you.
Yes. Smithy,
Thank
start.
you.
I am always
Thank
there,
you.
but you can introduce these people.
Sure.
Yes, sir. So,
Who is going to speak?
Dr. Anand Joshi is unable to join us. I would like to introduce Dr. Anita Jatana. She is consultant dietetics, Indraprastha Apollo Hospital, Delhi. And Dr. Umesh Khanna would also be co-chairing with ma'am. I'll request ma'am to please introduce our next speaker.
Anita.
Yeah, Dr. Anita.
So, Dr. Anita Saxena is the main pillar of strength for all of us to do the Srnmcon 2021. It is her enthusiasm and the energy which actually has risen Srnmcon from a simple nutrition conference to great heights. She is the professor of Department of Nephrology at the SGPGI, Lucknow. And for me personally, I have always liked the way she enthusiastically acts as a catalyst to all of us to do the kind of work which is reaches. Anita, over to you.
Right. Thank you, sir. Can you hear me?
Yes. Yeah, and before even introducing, I think I'm going to say a big thank you to Dr. Saxena.
What for?
For organizing this big conference and always taking the Sunday sessions on.
Oh, yeah, that's one. One is tomorrow. Let me just, the credit for this conference goes to Dr. Umesh Khanna. And I'll get on with my my talk, because what is happening is you're just telling people to rush. Right. Okay. Good evening, ladies and gentlemen. I'm going to talk to you about, is diet a risk factor for multiple myeloma? Now, we know that the patient with multiple myeloma presents to us with acute kidney injury. So acute kidney injury has been dealt with already in the first session. So I'm not going to talk about that management. It's a general thing that I'm going to talk to you about. And it is that I start with Hippocrates, the father of modern medicine, who said that cure sometimes, treat often, and always, and comfort always. Now, over 150 years ago, a 45-year-old London tradesman, Thomas Macbean, one day, while walking, stumbled, fell, and was seized with a severe pain in his chest. Over the course of 2 years, he was treated for recurrent severe pain with a variety of treatments, plaster to the chest, removal of a pound of blood, maintenance therapy consisting of application of leeches and later cupping and steel and quinine. Remission from this last treatment was, as was the case with all others, did not last long. Now, Mr. Macbean's consulting physician, McIntyre, recognized the features of Benz-Jones proteinuria, and when Macbean's pain recurred, he consulted Henry Ben-Jones, who erroneously concluded that the protein that precipitated when Macbean's urine sample was heated a little above 50 degrees centigrade and cooled was a hydrated deuterium oxide of albumin. Benz-Jones recommended that any patient with mollitus osseum, that is softening of bones, should be examined for this particular protein. Now, multiple myeloma, we all know, is the second most common hematological malignancy that is responsible for nearly 20% of hematological malignancy-related deaths and has shown a uniformly increased incidence since 1990. The median age at diagnosis is 69 years with male sex, African ancestry, family history of hematological malignancies and obesity being established risk factors for it. Now, in India, the incidence of multiple myeloma is stated to be 1.13 per 100,000 in men and 0.81 per 100,000 in females. Now, the common manifestation of multiple myeloma patients exemplified by the acronym CRAB includes hypercalcemia, renal failure, anemia, bone disease in the form of osteocclusion, pathological fractures, or diffuse osteopenia. Now, multiple myeloma patients typically present with complaints of fatigue and unremitting bone pain. Infections are a major cause of morbidity and mortality, and the risk of infection increases with active disease but decreases with the response to therapy. Now we know that the clinical presentation of multiple myeloma is either in the form of gastronephropathy, interstitial nephritis, infiltrations, lymphoma, MCD, MPGN, or and heavy proteinuria, and they present normally to us as acute kidney injury, and then we find that the patient has multiple myeloma. But I'm not going to talk about that. World of Cancer changed in 2005 with diet and lifestyle changes developed by Dean Ornish, which included 19 cancer-inhibiting vitamins, minerals, herbs, effective in halting and reversing the progression of slow-growing but potentially fatal prostate cancer. The new 4 basic groups that he talked about were fruits, vegetables, whole grains, and legumes. Now, he claimed that faster-growing cancers can be slow to the point that Ornish diet will stop them. This diet can be viewed as a 3-legged stool with each leg representing a central aspect. Take away one leg and the stool collapses. And the 3 legs are no animal products, avoid fatty vegetable fruits, particularly nuts, eat only whole fruits, eliminate all added sugar and corn syrup, and sugar naturally present in the food is okay. So is diet a risk factor for multiple myeloma? Diet may influence risk for multiple myeloma by modulating pathways for it, though the literature is limited. Now, this paper, that is dietary patterns and risk of multiple myeloma in 2 large prospective US cohorts, was the first evidence of the role of diet with higher inflammatory or insulinemic potential in multiple myeloma development, and it was conducted on 69,000 females and 47,000 males between 86 and 2014. Now, the first, so they studied 7 diet pattern indices, and they said the subjects with high alternate healthy eating index, Mediterranean diet, DASH diet, and protein pattern, which emphasize on high consumption of vegetables, fruits, whole grains, nuts, legumes, long chain fatty acids, and omega-3 fatty acids, polyunsaturated fatty acids, and lower consumption of sugar-sweetened beverages, red processed meat, sodium trans fats, and moderate alcohol. They all tended to have lower BMI, higher physical activity, lower intakes of red and processed meat, refined carbohydrates, and sugar-sweetened beverages, and higher intakes of whole grains and fruits and vegetables. Now, this is what I've just shown you. Now, on the other hand, the Western pattern included the dietary index for insulin resistance, inflammatory pattern, and hyperinsulinemia, which emphasized more on processed and red meat, beef, saturated fats, creamy soups, margarine associated with hyperinsulinemia, and showed opposite trends in the general. And this is what I've been talking about. This is the table from the publication. So positive association of inflammatory pattern in men was consistent with hypothesis that immune modulating or pro-inflammatory factors influence multiple myeloma risk and were predictive of CRP levels, IL-6 and TNF-alpha. Dysregulation of endogenous growth factors such as insulin-like growth factor 1 and insulin also contribute to pathogenesis of multiple myeloma. So the insulin resistant diets and the hyperinsulinic diets, which were derived to characterize the insulinemic potential of diet, particularly related to insulin resistance and hyperinsulinemia respectively, and had positive association as risk for multiple myeloma. Now, if you have a look at this figure is showing you this one, where I've shown the red arrow, that cultured bone marrow mononuclear cells from multiple myeloma patients express CD138, showing that circulating insulin present in human AB sera could be partially responsible for the multiple myeloma cell growth activity of the serum. And then it was confirmed by adding increasing concentration of human AB serum, which increased the growth of myeloma cells. Now, this figure is showing you the highest 42% IL-6 serum levels in patients And this one is showing you the IL-6 receptor levels in MGUS patients, and it controls the minimum, the maximum values. So systematic literature review, another publication, identified food patterns predictive of for individual sets of inflammatory and metabolic markers like high density lipoprotein and or blood glucose. So these are several food patterns. This is the summary of studies associated with inflammatory biomarkers and dietary patterns, which has shown that the vegetable-based and the fruit-based diets have, they do not have increased CRP levels. However, when you come across meat and processed food-based diets, then you have high CRP levels and IL-6 and IL-18 levels. So IL-6 and IL-18 had positive association with patterns high in red and processed meat and low in vegetables and fruits. And the patterns inversely associated with CRP concentrations were characterized with high loadings of fruits and vegetables, whole grains, or fish. And so this is the message throughout. And then diets based on bread also did not show any increased CRP levels. However, dieting was a very good study here, that adiponectin was high on dieting with low sugar, low fat dairy products, lasagna, low in butter and sweet condiments, because increased adiponectin levels, which is good, is associated with increased insulin sensitivity by improving glucose and lipid metabolisms. And healthy diets favored good inflammatory profile. And this table is showing you the different kinds of diets. And the message here is the dietary pattern indices promoting inflammation, insulin resistance, and hyperinsulinemia have positive association with risk for multiple myeloma. Now, on diet and nutrition as risk factors for multiple myeloma among Blacks and whites in the United States has shown that high risk for multiple myeloma was associated with intake of more than 1,200 kilocalories from foods per day and in overweight and obese subjects. And this particular table is showing you odds ratio for multiple myeloma in whites and Blacks according to consumption of food. And the message here is that the consumption of some vegetables had protective effect, and a reduced risk was associated with the frequent consumption of cruciferous vegetables. And with increasing intake of cholesterol, significant increase trend was of increasing risk was evident for whites. And with consumption of vitamin C from fruits and fruit juices, significant positive gradient was observed in the risk. So excess calorie intake and obesity may act as immunological responses that are involved in the development of this malignancy. And a meta-analysis of 10 prospective cohort studies has shown that an increase in the incidence of myeloma for each increase in BMI of 5 kilograms per meter square over 25 kilogram meter square of BMI is there. So we have to be careful with the weights. Now, cooked tomatoes, cruciferous vegetables, fresh fish, vitamin A had inverse association with multiple myeloma risk, and protective factor here in these studies was that fish contain a lot of vitamin A and omega-3 fatty acids. So was it the effect of vitamin A or was the effect of omega-3 fatty acids? It's still not known. Now, cream soups, jello, ice creams, milkshakes, and puddings were positively associated with multiple myeloma risk. And here you can see this is the antiproteinuric effect of omega-3 fatty acids, and we all know about this. Now, use of any vitamin was really good for in both the whites and the Blacks, but use of vitamin C supplement was associated with reduced risk in whites, but not in the Blacks. So this study, whole grain food intake and cancer risk, has shown that high intakes of whole grain foods consistently reduces risk of neoplasm. And for lymphomas and multiple myeloma, it is the odds ratio is 0.5. Now, alterations of gut microbiome accelerate multiple myeloma progression by increasing the relative abundance of nitrogen recycling bacteria. So there is an underlying association between gut microbiome and the multiple myeloma. You find gut microbiome working everywhere now. See that be that cardiovascular disease or progression of CKD. So it's everywhere. So metagenomic sequences of fecal samples showed a significant difference in bacterial composition between 37 patients and 18 healthy controls, and enrichment of nitrogen cycle recycling bacteria in multiple myeloma. A subsequent study by the same group showed that fecal microbiota from multiple myeloma patients, when transplanted into mice, showed significantly accelerated progression of multiple myeloma tumors. So where do this take us to when it comes to a CKD patient who is advised restricted diets? We've been hearing about this throughout. So where does our patient fit in? I mean, when he's on treatment, what do you give him? If plant-based diets are the answers to reducing risk and progression of multiple myeloma, patient already has multiple myeloma and is already being treated, then how do we address issues like hyperkalemia and hyperphosphatemia in CKD patients? I leave these questions to all the dietitians. They have to find an answer to it. So the take-home message of my talk here is the diet can have a preventive effect on risk for multiple myeloma. Diet with inflammatory or insulinemic potential may play a role in the development of multiple myeloma. Greater consumption of fish and cruciferous vegetables, fruits, whole grains, nuts, and less consumption of desserts and sweets, as in Mediterranean diet or the DASH diet, may lower risk for multiple myeloma and its progression. For good response to treatment, consumption of and insulinemic foods may be reduced, which is what I think. And underlying association between gut microbiome and multiple myeloma is definitely there. And supplementation with vitamin A and C can really help these patients delay the progression of disease. And thank you so much for your attention.
Excellent talk, I think, on an offbeat topic, which is not commonly talked about. So really impressed, and I never thought that there could be a talk on specifically diet in multiple myeloma.
Dr. Umesh, before I could ask Dr. Khanna the question, she's put the ball into the dietitian's court. My question was going to be, and I'm still going to ask her, how do you manage CKD with multiple myeloma? Because there's so much of restrictions for them, and you are advising fruits, juices, vitamin C. So let's hear from you. And then I think, as you said, the dietitians will take over from there.
All right. Okay. My take on this is, well, because our patients, they do have a high serum creatinine, and when they come with AKI, of course, and they are, so we put them on, first of all, we treat them with, as you would be managing patients with AKI. Right. And once AKI is resolved, then the question is, where is the serum creatinine sticking to? Like, has it gone back to the previous, or is it really gone up, or the patient is going to be on dialysis? So that will again decide how to do. Fruit juices and all are a big no-no, that CKD, when it comes to CKD, like, even if it's a diabetic, you're going to stop all kinds of roughage, plenty of roughage you stop. So the same thing is happening. This is a thought-provoking talk that I said you must think over it. So, and this is basically for the general population, because we are low on vegetables and fruits, we are more on junk food. So this is a talk for everyone. It's not just for our CKD patients. When it comes to a CKD patient, you can't do anything because your hands are tied. And the plateau diet that you're going to hear tomorrow morning at 9 o'clock is going to talk about, a plant-dominated diet. And plant-dominated diet, well, it's welcome, but how do you tackle hyperkalemia? How do you tackle hyperphosphatemia? Okay, I agree that hyperphosphatemia is not such a problem with plant diets, because only 30 to 40% of plant phosphorus will be absorbed. But hyperkalemia, you want to put your patients on resins throughout? I don't think it's a very good idea. I mean, we are, falling back on the resins, on all the new kinds of anti-hyperkalemic measures that are coming, the zirconium and all those things. But how safe are they? I mean, how can a patient be on them forever? So that's what I have to say.
Dr. Saxena, just another question. For Magus is reversible, sort of, if you can prevent it from its going further on to multiple myeloma?
I said just one point before people feel that there is an entertainment program after that. Let me remind people that we have the Hall A continuously going on. And after this session is over, one can move on to Hall A till 7:45. So people should not feel that after that you can go home and join Srnmcon entertainment program. The sessions are on in Hall A. Yeah.
No, we do have oration later on.
Yes, yes. So that's what I'm trying to say.
Waiting for 8 o'clock. What time is it?
7:40 till 7:45. Everything is there in Hall A now. Hall B will be over after your talk.
Plenary has started in Hall A. The foreign speaker session has started already. I would request everyone.
Oh.
Yeah,
to
shift over to
Hall.
Hall.
Like to join the foreign speaker session.
Yes, yes.
Yeah, okay.
Yeah, so we'll close this after whatever. Yeah.
Great. Thank you so much.
Thank you.
All right.
So thank you, Dr. Anita Saxena. Thank you, Dr. Jatana, and thank you, Smriti, for anchoring the session.
Thank you, everybody, for this great opportunity. Thank you, Dr. Umesh.
Thank you.